Sorry for that. So to save your time and make your journey easy, we are going to provide you an organized list of prompts under specific systems. There are 78 prompts from different systems like neurology, gastrointestinal tract, musculoskeletal system, cardiology, respiratory system, renal, endocrine, dermatology, and so on. First, let me tell you what is prompt. Prompt is the given symptom at the long clinical consultation station at the PACES exam, like the low back pain, headache, blood in the urine, that is hematuria, abdominal pain. So what is unique in this course is that we are going to teach you first about the approach for individual prompt. Then we are going to make you practice. For practice, we also have another unique way. We have collected over 250 real PACES exam cases from the last 3.5 years. What we are going to do after discussing prompts from each system, like the musculoskeletal we will discuss today, like from the musculoskeletal system, we have over 30 cases that are real PACES exam cases that have appeared in the PACES exam. All of the cases are typed in the PDF format in details. So after today's session, we'll form group between active participants. We'll give access to all the PDF of that system. Also, at the same time, there will be another bonus. That is the recording of the physical examination, investigation, and management for each case. Total more than 250 cases separately. Recording will be provided to the active participants. Your job will be to take preparation in details for each of these cases separately. Then you have to start practicing this with the other group participants with the assigned homework, and then you have to give regular feedback to the mentor directly. During the next session, each one has to do one-to-one practice with the mentor. Then we'll proceed to discuss the next system prompts. In this way, this course will be completed on 10th session, and the 11th session will be solely on practice. Each week, we will have 2 sessions on Sunday and Wednesday. So the course will run in this way. I hope everybody has understood. Please ask me if anyone have any kind of confusion about the course structure. Then I shall enter into discussion of the main PACES exam LCC format. Do anyone have any kind of question? Okay. Let me start discussion about the PACES exam. So before starting for discussion about the PACES exam format, we need to understand the question, the mark sheet, how the marks are distributed for each skill. Like the first skill is physical examination. The second skill is identifying physical sign. Third skill is clinical communication, then differential diagnosis, clinical judgment, managing patient concern, and maintaining patient welfare. Each skill I'm going to discuss one by one separately. But before that, I have to discuss something new that you will find in this course. That is the conception of CCCA. So what does this CCCA mean? During approaching for each long clinical consultation station, we have to form this CCCA. We have to follow this pattern. So the first C goes for confirm. The second C goes for finding out the cause or trigger. The third C is for finding out the complication, and A goes for ruling out association. All these CCCA has to be excluded from the history, physical examination, and investigation. Let me give you an example. During our discussion, I'd like to have some active participation. It will be easier for me to make it understand. Like, there's a very much common prompt in the PACES exam that is swallowing difficulty. This swallowing difficulty approach will be discussed during our GIT prompt discussion. So suppose you have been given a case of swallowing difficulty that causes myasthenia gravis, and your diagnosis is myasthenia gravis. This sound coming in. Please mute everyone so that my sound is clear to everyone. Okay. So my diagnosis is myasthenia gravis. So first we have to confirm my diagnosis of myasthenia gravis. Then I have to find out the cause or trigger of myasthenia gravis. Then I have to find out the complication of myasthenia gravis. At last, we have to find out the association of myasthenia gravis. So how this is found? So to confirm a myasthenia gravis, I have to confirm it first from the history. I will teach you individually how to confirm from the history the diagnosis of myasthenia gravis. Then from the physical examination, I have to confirm that this is myasthenia gravis. Then during training investigation, to confirm my myasthenia gravis, I have to tell certain investigation. Also, so during management, I have to manage the myasthenia gravis. So let me start one by one. So to confirm my myasthenia gravis, in the history, from the history, we have to confirm that this is a myasthenia gravis. Then from the history, we have to find out the cause or trigger. So can anyone tell me what is the cause or trigger of myasthenia gravis? The cause is autoimmune cause. And most of the cases, there can be some trigger, like recent infection or antibiotic. So we have to identify it. We have to identify it from the history. Then from the history, we have to rule out the complication. How to rule out the complication? The complication of myasthenia gravis is breathing failure. So from the history, we have to find out whether there is any respiratory failure. Another complication of myasthenia gravis is aspiration pneumonia due to swallowing difficulty. So from the history, we have to ask whether there is any cough and does he produce any film to exclude the aspiration pneumonia. Then we have to rule out the association from the history. How to rule it out? Myasthenia gravis is an autoimmune disease. We have to rule out other autoimmune diseases. What are the other autoimmune diseases? They are DET, CPR, MV. This is the mnemonic to remember all the autoimmune diseases. Here D goes for diabetes, A goes for Addison's, T goes for thyroid, C goes for celiac disease, P goes for pernicious anemia, R goes for rheumatoid arthritis, M for myasthenia gravis, and sorry, it will be not G, it will be P. V goes for vitiligo. So from the history, we have to ask about the symptom of diabetes, Addison's, thyroid, celiac, pernicious, rheumatoid arthritis. All these we have to rule out. This has to be done from the history first. Then come to the physical examination. In the physical examination, first we have to confirm that this is myasthenia gravis. How to confirm it? I will give you detailed recording of the steps of examination of myasthenia gravis in the later. So from the examination, we have to confirm that this is myasthenia gravis. Then, to find out the cause or trigger, actually there is no physical examination. So this indicates that all these components you will not find in all the cases. Like in case of myasthenia gravis, during physical examination, to find out the cause or trigger, we don't have to do any physical examination. Is that clear to everyone? This is a very much important concept to understand and proceed to the course. Dr. Shushmita, are you clear?
Yes. Yeah.
Okay. Then let's come to the complication. So what is the complication of myasthenia gravis? The complication is breathing failure and aspiration pneumonia due to swallowing difficulty. So from the physical examination, during physical examination, we have to rule out the complication. How to do it? We have to offered to measure bedside forced vital capacity. And also, we have to auscultate the lung, excluding any aspiration pneumonia. In this way, we are ruling out the complication. Then come to the association. So from the physical examination, how to rule out the association? For diabetes and Addison's, we have to measure the bedside blood sugar and sitting and standing blood pressure. To rule out thyroid association, we have to check for neck swelling. We have to tell the patient, take a sip of water, don't swallow it until I tell you to swallow. Then celiac disease can be ruled out only from the history, not from any physical examination in this case. For pernicious anemia, we have to look for any conjunctival pallor. Also, we have to look at the tongue looking for glossitis. For rheumatoid arthritis, if there is no history of joint pain, we don't have to do any physical examination. The case is itself myasthenia gravis. To rule out vitiligo, we have to tell the examiner that I want to do full skin survey, ruling out any hypopigmented skin rash that is vitiligo. So in this way, from the physical examination, first we have to confirm our diagnosis of myasthenia gravis. Then we have to find out the cause or trigger. In this case, no physical examination is there. Then we have to rule out the complication. Then we have to rule out the association. So this is the conception of CCCA. So in this way, we have applied it in history taking and physical examination. Now let's come to the investigation. So if you approach in this way, in the physical examination, you will not miss any important examination. So in the investigation, how to tell this? Always start from the saying that apart from basic investigation. Because without saying this, you cannot start any investigation. So when replying for any investigation, start like apart from basic investigation. First, to confirm my diagnosis, I have to do certain tests. Then to find out the cause or trigger, I have to do certain tests. Then complication, last association. So to confirm my diagnosis of myasthenia gravis, what investigation we have to do? We have to do anti-acetylcholine antibody test or anti-mask antibody test. Also, we can do single fiber electromyography, repetitive nerve condition study, and that's all. Then to find out the cause or trigger, we have to do that drug screening, like whether the patient has recently taken any azithromycin. We have to check from the basic investigation, from the complete blood count, whether there is any evidence of infection, because infection is a risk factor, is a triggering factor for myasthenia gravis exacerbation. Then for the complication, we have to do spirometry. Okay, one candidate has told me to elaborate on examination. Okay, I'm telling it later. So for the complication, ruling out complication, we have to do the spirometry. From the spirometry, we have to rule out the respiratory failure. Then we have to do the chest X-ray. What we'll see in the chest X-ray? We'll see in the chest X-ray whether there is any consolidation, ruling out aspiration pneumonia. Then to rule out the association, what we'll do HbA1c, fasting blood sugar, HbA1c, ruling out diabetes. We'll do 9 AM serum cortisol, ruling out Addison's disease. We'll do thyroid function test, ruling out any autoimmune thyroid association. So in this way, we'll tell every test to rule out every autoimmune disease. It's not that simple. I can guarantee you, if you tell in this way, you're going to get the full mark. And the examiner will not derail you to any part, because the PACES examiner are so much helpful. So they want you to be a safe doctor. So if you start like this, apart from basic investigation, to confirm my diagnosis, to find out the cause or trigger, to find out the complication, then to rule out the association, you will not miss any important part in the investigation. So I'm again repeating the physical examination sequence because one candidate has requested. So what we have to do in the physical examination? Suppose you have been given a certain prompt. In this prompt, the prompt was swallowing difficulty. And the diagnosis of swallowing difficulty is myasthenia gravis. So from the physical examination, we have to confirm that this is a case of myasthenia gravis. That is our first job. Anything, any prompt given, we have to first confirm our diagnosis from the physical examination. Then, if it is possible, we have to find out the cause or trigger from the physical examination. But it is not possible for every prompt. Listen to this. Then, from the physical examination, we have to find out the complication. Then, from the physical examination, we have to rule out the association. So, how to confirm the myasthenia gravis? There is a sequence of steps of examination that has to be done for myasthenia gravis. This is a long thing to discuss, and I have there is a recorded video of mine which will be provided to the active participants. What are the steps of examination of myasthenia gravis, starting from the ptosis, how to approach ptosis in case for each case. So these are the conception of CCCA. Please tell me anyone if anyone has any kind of confusion regarding the conception of CCCA, because this is one of the most unique thing of this course. If anyone has any kind of confusion, I'm ready to repeat it once again. Please share your view. If it is okay, please give a thumbs up to the reaction. Do anyone have any kind of confusion about the approach to CCCA? Okay, let's proceed. Next one. Now I'm going to discuss about each and individual skill of the PACES long clinical consultation mark sheet. Why this is important? Because the motto of this course is to make you self-sufficient. Because this is a one-time course. We don't want you to repeat this course again. We will give you all the things that you need to pass the MRCP PACES long clinical consultation station. That is 28 out of 28 marks in both stations. So to make it, we have to make a mentor of each of you. We have to know how the examiner thinks, how the marks are distributed according to each skill. So let's start. So in the PACES examination, you'll be given a prompt. The prompt will be given here, like this is from low back pain, suppose. So there will be two examiners inside the station. Each examiner will have this mark sheet at his hand, and each examiner will be assigned for only 14 marks, not more than 14 marks. So after combining both examiners, you will get 28 out of 28. So how the marks are distributed? From the screen, you are seeing that there are three skills, three types of judgment. One is satisfactory, another one is borderline, another one is unsatisfactory. If the examiner thinks that your skill is satisfactory, then he will give a marking here. He will give a mark here, so, and you will get 2 marks. If he thinks that your performance is borderline, then he will give a mark here, and you will get 1 mark in that skill. And if this is unsatisfactory, you will not get any mark, that is 0 mark, and you will get 0 mark in that skill. And why you have been given 0 mark, the examiner will write here the reason for giving for you to avoid. So in this way, the mark is distributed. So how the marks are assessed? Let me discuss you. In the physical examination, if you follow the format of CCCA, that is to confirm a diagnosis, to find out the cause or trigger, to rule out the complication, and to find out the association, you will not miss any important physical examination you have to do in the PACES exam. This is my guarantee. And I will guide you at each step for each more than 250 cases. These 250 cases are the real PACES exam cases that I have personally collected over the last 3.5 years. These cases have come at multiple centers at different times. These cases are not synthesized by myself. These are real exam cases. So my suggestion will be to follow the CCCA format to get 2 out of 2 in the physical examination section. Then identifying physical sign. For this skill, I have to tell you something important. In the PACES exam, 2 types of cases are given. One is real patient. Another is dummy patient. So in the PACES exam, not all the time they will give you real patient. At many times they can give you dummy case, and sometimes happen both the long clinical consultation station you can get dummy case. That has happened during this diet in the Delhi. So in the PACES exam, one thing is very important. Omitting is better than, I will tell it, committing. What does this mean? This means synthesizing any physical finding is a great sin in PACES exam. If you synthesize any physical finding, you will automatically get 0 in identifying physical sign. It is for sure. Whether you have identified many wonderful physical findings, if you synthesize any one positive physical finding, you will get 0. So why this is important? Sometimes dummy cases are given in the PACES exam. So in the dummy case, the examiner will ask you, what are your positive physical findings? Tell me the positive physical findings. In that case, if you tell something to synthesize, like there is a very much common case that is after taking NSAID, patient is having hematemesis. So this will be typically a dummy case. You will be given a medical student. He will tell you that recently I have played a football match and I have got hurt. After that, I have taken painkiller, but I did not take the tummy protective medication. Now I am having severe hematemesis. But after examining, you will find that the patient is not having any anemia. So by matching, if you tell that I am finding anemia, you'll automatically get unsatisfactory here. And the examiner will poke you every time, any positive physical finding. So my suggestion will be, either you are not that much confident, don't synthesize for any physical finding. Rather, be silent. Because if you synthesize even one positive physical finding, you will automatically get unsatisfactory in this case. And whenever the case is dummy, you have to tell that I have not got any positive physical finding. This is for sure. I am telling again, once again, in the PACES exam, there are 2 types of case, dummy case and real case. For dummy case, you will not get any positive physical finding. So never dare to synthesize any finding, because in the PACES exam, if you ever dare to synthesize any finding, you will get automatically unsatisfactory here. Whether you have identified 5 or 6 wonderful physical findings, but even if you synthesize one positive physical finding, you will get unsatisfactory. And for the real cases, don't utter anything whether you are not confident enough about the positive physical finding. If you are not confident enough that these findings is there, be silent. But don't tell anything that you are not confident, you are confused. So this is the number 2 skill, that is identifying physical sign. So we have discussed the physical examination, identifying physical sign. Now let's come to the clinical communication skill. This is the most difficult skill that most candidates suffer for. And regarding this skill, we have to spend a lot of time and we have to do a lot of hard work. So this course is there to make this skill easier. So let's start this. So this clinical communication skill is basically format of history taking. I'm going to discuss it now. After that, I'm going to discuss the differential diagnosis, clinical judgment later on. So this is a simple flowchart of clinical communication skill, that is history taking. After entering into the station, you have to do some introduction. You have to tell like that, hello doctor, I'm Dr. De, one of the doctors working here today. You have to put some smiley face. By putting this smiley face, you will give a gesture to the examiner that you are a professional. Then you will tell like, I am here to talk to you about your problem and examine you. Is that okay? If at any point you have a question, please feel free to interrupt me anytime. Also tell the surrogate that I may take a few notes during our conversation, but rest assured, everything remains confidential, because confidentiality is a great issue in PACES exam. Then start with the open question, like, so in your words, could you please tell me what brings you here today? Never go for any closed question, like from your note, I have come to know that you have swallowing difficulty. Don't go for that. Ask open question. What brings you here today? So this will be the introduction. After introduction, you have to do the symptom analysis. So what is symptom analysis? Let's go for it. For the symptom analysis, I have made a mnemonic, that is ODPARA. You can use this symptom analysis, this mnemonic for any symptom. But there are certain symptoms where this mnemonic does not fit. And for this symptom, what will be this, how you will analyze the symptom? I will give you a specific line to analyze. Whenever the prompts arise, I will tell you during the course period. So what goes for ODPARA? Here O goes for onset. How did the symptom start? Did it start suddenly or gradually? It will help you to understand whether it was sudden onset or gradual onset. Then duration, for how long you are experiencing this symptom. Then I goes for initial period, whether this is the first time he is having this symptom. Like the patient has come with headache. We have to ask, is this the first time you are having this kind of headache, or you are having this headache from very earlier time? Then P goes for progression. We have to ask, do you think your symptom is gradually increasing day by day or gradually decreasing? Then A goes for aggravating factor, R goes for relieving factor. We have to ask, anything increase or decreases symptom? Then last A goes for associated features. This will not fit for everything. I will tell you what each prompt where fits it and where it does not fit. So here goes for ODPARA. O for onset, D for duration, I for initial episode, P for progression, A for aggravating factor, R for relieving factor, and A for associated feature. The next important thing is regarding pain. Whenever there is any pain, the first question will be whether there was any history of trauma. This is the first question. Any pain, we have to ask whether there is any history of trauma. Then we have to analyze the pain using the mnemonic LICOR. This is my personal mnemonic. You can have your own one, but this is easier to use. So what goes for LICOR? Here L goes for location, I goes for intensity, Q goes for quality, AR goes for radiation. Each one is very much important. L goes for location. For the location, we have to ask, where do you feel the pain exactly? This is a very much important question for any kind of pain. It has happened for multiple times in the PACES exam, like the patient has come with hand pain, but the candidate did not ask, where did you feel the pain exactly? That is why he lost his mark in the clinical communication skill. And the mark is very much narrow. The therapeutic index is very much narrow, that is 2. So if you make mistake in one thing, you will automatically get 1. Then another case came in the Pondicherry. That case was low back pain. So everyone understand things that for the low back pain, that can be a case of musculoskeletal. But that was a case of pyelonephritis. So many candidates made the mistake. The candidate who asked, what is the site of your pain? After the patient shows him that I am feeling pain at my lumbar region, at that time, the diagnosis was confirmed. So location is very much important. You have to pinpoint, you have to localize where he is feeling the pain. Then I goes for intensity. You have to tell how severe the pain is, 1 being the lowest and 10 being the highest. Then Q goes for quality. You have to ask, what is the quality of the pain? Can you describe it for me? Then radiation. After starting from here, does it go anywhere else? So this is the LICOR. And for any pain, if the pain is 10, 6 out of 10, we have to admit the patient. This is a must. If the pain is more than 6 out of 10, we have to admit the patient. And whenever any patient has come to you with the pain, you have to ask the patient, do you need any painkiller from me? This will ensure that you are a safe doctor. I am telling again, whenever any pain comes in the PACES exam, we have to ask, do you need any painkiller? If the patient tells you that, yes, I'll be happy for that, then you will have to tell the patient that after our conversation today, I will arrange some painkiller for you. So this goes for LICOR. So for any symptom analysis, we can use the ODPARA, and for the pain, LICOR. So let's go to the next part. After symptom analysis, we can go for systemic review. But there is a trick. This part is a hack. There is a hack. So what is the hack here? Without going to the systemic review, if you go to the past medical history after symptom analysis, in more than 80% of the cases, you will get your diagnosis. This is my 100% guarantee. I'm telling it once again. So let me tell you what is PDF. Here P goes for past medical history, D goes for drug history, and F goes for family history. For the past medical history, you have to ask each of these 7 questions specifically. You have to ask, do you have any past medical condition that I should be aware of? Any surgery before? Some candidates ask that, do you have any past medical condition? If you ask in this way, sometimes the surrogate will not give you some other important information. Like that happened in my case. I got a case of headache. So I asked the examiner, I asked the surrogate, do you have any past medical condition I should be aware of? He denied. Then I asked him, any surgery before? After that, he replied that, yes, I had a traumatic road accident. After that, I had a surgery at my tummy. That was a case of splenectomy. So you have to ask specifically each of the 7 questions. So for the active PETS participants, I will provide this PDF to each candidate, and I will suggest everyone to memorize these 7 questions because these are very much important questions, and you will automatically get it to the diagnosis from the past medical history. Like any blood transfusion, any recent procedure like dental procedure, any recent infection, I will tell you, I will give you real basis example why these questions are very much important. Any recent contact with sick patient, any recent innovation of home. Then in the drug history, we have to ask, do you have any medication list? May I have a look? We have to check for the compliance. The most important thing in the drug history is the medication allergy. I'm telling it, the most important thing in the drug history is the medication allergy that most of the candidates don't ask, because this is very much crucial for the UK examiner. They like it a lot. I'm giving you a real example. This Delhi, diet in the Delhi, one of our course participants attended an exam. So he got a case of diarrhea. That was loose motion. And the diagnosis was differential diagnosis, IBD flare-up, infection, and malignancy. During my course practice, I emphasized to ask about the medication allergy. So he was the only candidate, he was the only guy in his diet, in his carousel, who asked about the medication allergy. And the candidate replied, and the surrogate replied, yes, 5 years back, I had taken a medication for my loose motion, and at that time, I had some allergy. So the doctor told me that I am having penicillin allergy. That penicillin allergy was having nothing to do with the real diagnosis. But considering the UK perspective, this is very much important. And he is the only guy who has identified this medication allergy because he have specifically asked about the allergy to any medicine. That is why he was the only candidate from that carousel who could identify the medication allergy. Rest of the candidate couldn't identify it. And automatically, it will cut mark in the clinical communication skill for sure. That is why I am requesting everyone not to miss the allergy to any medication, because this is considered very much important for UK perspective. They are very much, the UK examiner are very much allergic to the medication. This is for sure. Then family history, any disease running in the family, any one of the family member having similar problem. So this goes for past medical history, drug history, and family history. Then if there is travel history, we have to ask before, during, and after. So before we have to ask specific question, during we have to ask specific question, and after we have to ask specific question, all will be provided to you. So what I'm going to tell you right now, that after doing symptom analysis, if you want to reach your diagnosis, go to the PDF directly. You will get your diagnosis in more than 80% of cases. It is my 100% guarantee. Let me give you an example. These are real cases example. And I will like to have active participation from the candidates. Let me see who can give the answer. So at one time, Bangalore, this is a real exam case. That was a case of fever. And I personally talked to the candidate who appeared at the exam. he was telling me that he was not giving any positive history. There was no past medical history. At the very last, he was asking any recent procedure, like any dental procedure or any recent infection. After that, the surrogate replied that yes, not recently, 2 months back, I had a dental procedure. No other positive history. That was a dummy case. He was having fever for 2.5 months, and he had dental procedure 3 months back. So can anyone tell me what is the diagnosis here? Please unmute yourself and tell me the answer. One has given the answer in the chat box.
Endocarditis, bacterial endocarditis.
Yes, exactly. That was the diagnosis there. And on the physical examination, there was no positive physical finding. This is real PACES exam cases. Let me give you another example. This is a Delhi case. This has come many times, and this has come today even. Today at the Delhi center, this case has come. So the patient has fever. In the past medical history, the patient is telling that he is a kidney patient and he is taking dialysis through the arteriovenous fistula. So what do you think? What came the diagnosis here?
AB fistula infection.
Wonderful, doctor. Yes, Dr. Sushmita. AB fistula infection. This has come in the PACES exam many times in the Delhi center. Let me ask you another question. This has happened for myself at the Pondicherry. Patient was having headache, temperature was high. In the past medical history, like I have told you, he has a history of surgery, tummy surgery. He could not reply, but whenever I removed his gown, I saw that it was a splenectomy. So he was a history of splenectomy. Right now, he is having headache with meningitis. So what do you think? What is the diagnosis here? What important history we have to ask to this patient? Can anyone answer me?
Contact history.
Yeah, contact history. Apart from contact history, what this patient is.
Vaccination.
Yeah.
Vaccination.
Wonderful. Yes, yes. Very good, doctor. Vaccination. We have to ask about the shots. Sorry. My connection got. We have to ask about the shots. So I typically ask the patient, did you take your shots as prescribed by the doctor? The patient replied to me that no, I missed it because I am a poor man. I live in the slum. That's why I could not afford that. So I got my diagnosis.
Sorry, how do you ask for vaccination? Shots.
Shots. We have to ask shots. Vaccine will be a jargon. We have to ask that, did you take the shots as prescribed by the doctor? He typically replied me that no, I could not take it because I'm a poor, I live in the slum. At that time, I told him, okay, for your financial support, I'm going to refer you to the social worker, and that's all. Another one important history I have to take, that is medication history, whether he was taking the antibiotic. I was telling that, did you take the prescribed antibiotic prescribed by your doctor? Again, same answer. He told me that, I could not take it because I live in the slum, I'm poor. So my diagnosis was confirmed from that situation. I got my diagnosis from the initial. And I became very much focused. I then approached to the examination of the headache. I have a sequence of examination in written format, a flowchart I will give you. What are the steps of examination you have to do for headache? Any headache patients comes in the PACES exam, we have to follow this pattern. So that is why past medical history is that much important. Let me give you another example. You will get thousands of examples in the PACES exam. And this is a trick. This is a hack. If you go to the past medical history, drug history, or family history, after symptom analysis, in more than 80% of the cases, you will get your diagnosis. Suppose a patient has hematuria. In the past medical history, the patient has hypertension. In the family history, the patient is telling that his father died of brain stroke. That is bleeding inside the brain.
Polycystic kidney.
Wonderful, doctor. You have got a diagnosis. Polycystic kidney. Have you seen how much simple is it? Actually, long clinical consultation is not that much difficult that we used to think. It is very much doable exam. If you do regular practice, it is very much easy to get 28 out of 28. So let me give you another example. This is also a deadly case. That is hand pain. In the past medical history, the patient is telling that same thing, a fistula. He is a kidney disease patient, and he has a fistula. This case is coming today with both the symptoms, fever and hand pain. So what do you think? What is the cause of hand pain in this patient?
In epiphyseal infection,
Yeah, there can be many causes, like
others
Block.
maybe arthritis.
Some embolization of from the
yes,
fistula.
blocked. Some emboli causing blocking. Blocked fistula can be there, can be ischemic steel syndrome, can be infection. So this is a very much useful trick for the PACES exam to go to the past medical history, drug history, and family history as soon as possible. Let me give you another example. Patient has sore throat, prompt of sore throat. In the past medical history, patient is telling that I am a patient of Graves' disease, that is hyperactive thyroid gland, and I'm in the drug history, the patient is telling that I'm taking carbimazole. So what is the diagnosis here?
Granulocytosis.
Wonderful. Granulocytosis. See how much easy is it? And if you look over the 250 real PACES exam cases that I'm going to provide to each of you, to the applicant candidates, you will find that more than 200 cases, you will get to the diagnosis earlier if you approach to the PDF as soon as possible. So this is a tricks. Then this was PDF. The format is PDF Sajid. Another format is POET. So what goes for POET? Let me tell you. POAET. This is important only for 4 prompts. I'm telling you what does this mean. Cough, diarrhea, fever, and joint pain. So P goes for partner history. Sorry, P goes for pet history, whether he's raising any pet like pigeons. O goes for occupation. E goes for sexual exposure. And T goes for travel. POET is important only for cough, diarrhea, fever, and joint pain. I'm telling you, I'm giving you an example. Apart from these 4 prompts, POET is not important for any other prompt. Suppose the patient is having dry cough. And the patient raises pigeon. So he has a contact history of pigeon. So what can be the diagnosis here?
Extrinsic allergic alveolitis.
Extrinsic allergic alveolitis. That is why it is that much important. And also in case of diarrhea, for diarrhea, you have to exclude the exposure history. You have to take the travel history. Also, it goes for fever and joint pain. I have personally seen a feedback from Pondicherry Diet 2. That case was a joint pain. The diagnosis was rheumatoid arthritis, but the candidate did not take the exposure history. And the examiner, she was a Chinese examiner, she deducted his mark in the clinical communication skill. That is why I'm telling you, whenever you get any prompt like cough, this is a prompt for respiratory system, diarrhea, this is a prompt from GIT, fever, this will be discussed in the miscellaneous, and joint pain, this will discuss today. That is musculoskeletal. Whenever you will get these 4 prompts, don't miss to take the POET history, apart from the PDF Sajid. Sorry, apart from PDF, then goes for Sajid. Sorry, the slide is missing here. What goes for Sajid? Here, S goes for smoking. A goes for alcohol. J goes for job. I goes for impaction on daily life. And D goes for driving. So for each case, we have to touch the PDF Sajid. If you miss any point here, the examiner will cut your mark because you have to ask how this symptom is affecting your job and daily activity. Because you have to prove yourself that you are a safe doctor. Whenever the patient, you have to ensure the safety both at the hospital and also whenever the patient is reaching at his home. We have to ask him whether you need any support, like any patient of hemiparesis, any patient of Parkinson's disease, he will have some problem at his home. So if the patient tells you that, yes, I need some help, at that time, you have to refer the professional help. The help can be occupational health worker or it can be social worker. And also you have to ask about timing. So this goes for PDF Sajid. For cough, diarrhea, fever, and joint pain, we have to ask about POET. So this goes for the examination history taking format.
Can I ask one thing,
Yes.
doctor?
Yes, doctor.
So this POET is not important for any other symptoms apart
No.
from this?
No,
Even
I
if
don't
it
think so.
is- Even if we skip that exposure history in other cases, so it is not relevant.
I have not found it relevant to other prompts.
Okay.
That's why I
Yes,
have
sir.
made it separated.
Sure. Okay. Thank you.
Another thing is 5P. 5P is important in any case of reproductive age female. So what goes for 5P? 5P goes for pill, period, pregnancy, partner, and abortion. For abortion, I am telling it abortion to make it remember. So for any reproductive age female, we have to ask these 5P: pill, period, pregnancy, abortion, and partner. And these are personal questions. Before asking for any personal question, we have to do some safety netting. Like, I'm sorry to ask you some personal question. Is that okay with you? After telling this thing, we have to ask about, do you have any partner? Any other partner apart from casual partner? Do you take a birth controlling pill? How about your period? Do you have kids? Any episode of child loss or abortion? Is there any chance that you are pregnant? So in this way, we have to ask this 5P. Whenever the lady is postmenopausal, we have to ask, I'm sorry to ask you some personal question. Have you attained menopause? So this is the way you have to take any history. Symptom analysis, going to the PDF, POET, 5P Sajid, then you can go for systemic review. After doing this, you can be focused. You can become focused in the systemic review. This is not necessary to ask all the systemic questions. If you are confident enough to get your diagnosis, you can be focused for your diagnosis and also the differential diagnosis. So what are the systemic review questions you have to ask? I have provided all the questions in the PDF. Like for the general review, we have to ask about triple L, triple F. That is loss of weight, loss of appetite, lumps and bumps in the body. Triple F is fever, fatigue, feeling sick. And do you have any sweating? Then CNS questions are headache, dizziness, uneasiness, fits, double vision, difficulty in speech, any weakness. For cardiac, we have to ask about 4P. That is pain, breathing, palpitation, pitting, edema. For respiratory, we have to ask any runny nose, any throat pain, any cough, any bloody cough, any noisy chest. For gastro, difficulty in swallowing, heartburn. So these are the systemic questions. All the systemic questions are not necessary to ask for all the prompt. After you get to your diagnosis and you want to rule out a differential diagnosis, you can only touch that system. And this will be clear to you. After you complete this course, after you practice the 250 cases, it will be crystal clear to you how the cases come and what important question I have to ask. So this is the endocrine question. So this goes for the history taking format. And this comprises the mark in the clinical communication skill. Please ask me any question if anyone have regarding the format of history taking.
Can you please show the questions in the endocrine ones if you possible?
Sure. The screening question for endocrine only 2 or 3 questions. There is any neck swelling for thyroid, heat intolerance, handshake for hyperthyroidism, cold intolerance, constipation for hypothyroidism, any change in ring size or shoe size. These are just screening question. After you get your diagnosis, you have to ask specific question. Is it okay, doctor?
Yes, okay, thank you.
Okay. Then there is another thing. There are two things where most of the candidates face some problem. One is whether we have to admit the patient or not. Another one is whether we have to tell the patient to stop driving or not. These are the two things I have found most of the candidates find some difficulty. So in the PACES exam, you will be given two cases. One will be acute case and another one will be stable case. For the acute case, we have to admit the patient. And for the stable case, we don't have to admit the patient because the British examiner don't like unnecessary admission. So how to get out of this way? There are some cases where you will not confident enough. You will face some problem like, I'm not sure whether I have to admit the patient or not. At that time, there is a trick. You have to tell to the examiner that, you have to tell the patient that if the patient asks you, do I need admission? You can skip this way, like, I'm going to keep you at the observation room. In the meantime, my consultant will come and see you. We'll run some tests, and after all the test results are available, we will sit with you again. So you have not discharged the patient, not admitted the patient. You have just kept the patient in the observation room, and the consultant is there to support you. So this is proving that you are a safe doctor. So whenever you are confused that you are not going to admit the patient, you are not sure whether you have to admit the patient or not, you have to keep the patient to the observation room. This happens also with case of driving. There are some cases where we are not sure that whether we have to stop driving or not. And the many candidates spend their time memorizing the ruling, that criteria of driving, like for how long period we want to stop driving, for how long, after how long you have to start driving. Remember, this is not my job. In the UK, this is dealt with the DVLA. There is a separate department who will deal with this case. My job is to refer this patient to him. So for the PACES exam, for the long clinical consultation, whenever you are confused that you don't know whether you have to stop driving or not, you have just tell that stop driving till further assessment. So this will keep you at the safe side. You have not tell the patient that you can drive or you cannot drive. You have to tell like stop driving till further assessment. This will take you to the safe side. Is it clear to everyone about the admission and the driving? Anyone have any kind of confusion regarding the approach to history taking? Because this comprises the long, the clinical communication part. So after asking for Sajid, we can start for the examination. Then we have to meet the concern. So for the PACES exam, for the long clinical consultation, you will, for all of this, you will get 15 minutes. After 13 minutes, the examiner will tell you that 2 minutes left. So I will request everyone to keep these 2 minutes only for asking the concern. Because sometimes there will be 6 or 7 concern. The surrogate will have a written list at his hands, naming the concern. So you have to practice in such a way that you have to complete all the physical examination also with the history taking in this 30-minute periods of time. And this is very much doable. If you prepare earlier, what examination you have to do, what history you have to take. Because what I believe that in the exam center, actually central memory does not work. What works is the muscle memory. So you have to develop muscle memory, that is peripheral memory, first by reading, then doing practice. Without this, if you think that after going to the examiner, after going to the examination, I will think, then I will practice, then I will perform, then you are going to do something wrong. So this goes for clinical communication skill. You have to touch symptom analysis, you have to do symptom analysis. You have to ask PDF, Sajid, then 5P if needed. You have to ask about POET for 4 symptoms. Then you have to tell the patient whether you need to admit him or not. You have to tell the patient whether he can drive or not. All this skill will carry your mark in the clinical communication skill. And if you do well, you will get satisfactory. If you do borderline, you will get 1 mark. If you do unsatisfactory, you will get 0. And this is the only station where we have to do a lot of work to get the only 2 marks from each examiner. So these are the first 3 skills we have discussed up to now. That is physical examination, identifying physical sign, clinical communication skill. Now let's go for the differential diagnosis. So in the differential diagnosis, try to tell at least 3 differential diagnoses for every prompt. And how to tell this? Suppose, let me give you an example. Suppose in the case is swallowing difficulty. Okay, let me forget about swallowing difficulty. Let me tell you low back pain. We are going to discuss it today. So there are basically 2 types of low back pain. One is inflammatory and one is mechanical. And from the history taking, you have confirmed that this is a mechanical low back pain and that your diagnosis is osteoporosis. So you have to tell, like, my first differential diagnosis osteoporosis. Second is it can be disc prolapse, but against that I have not got any signs from the physical examination, right? Like any shooting pain, like in radiation the lower limb. My third differential diagnosis is vertebral collapse, but against that I have not got any point tenderness. So we have to tell our confirmatory diagnosis first, then we have to tell 2 other differential diagnoses at least. At the same time, we have to tell why this differential diagnosis does not fit here. Is it okay to everyone? And what are the differential diagnoses you have to tell? It will be very much easy to you after you complete the course, because for each prompt we are going to give you a formatted list of differential diagnoses. We are providing you some mnemonic how to remember the differential diagnosis. You will get it after doing the musculoskeletal prompt today. So this is for differential diagnosis, and I will suggest everyone to tell at least 3 differential diagnoses, and also tell why this differential diagnosis fits with this case and why other do not. And for this differential diagnosis, another important thing is there. That is, there are certain differential diagnoses in the PACES exam where they think one thing first. Let me give an example. Like, I got a case at my first attempt at Bangalore. The case was chest pain. And in my country, I don't get any pulmonary embolism case that much. So for the UK perspective, and also in the PACES perspective, whenever any chest pain comes, more than 90% case, it will be due to pulmonary embolism. This is for sure. I'm again tell you, in the MRCP PACES exam, whenever any chest pain comes, in more than 90% of the case, it is pulmonary embolism. And if you tell the pulmonary embolism at number 2 or 3 differential diagnosis, the British examiner will cut your mark. That has happened personally to me. My case was, she was a dummy case. She was a patient of COPD. She got admitted 3 days back. So she was suddenly having chest pain. So I told my first differential diagnosis is pneumothorax. Second or third was pulmonary embolism. I also rule out acute coronary syndrome, acute coronary syndrome. So what I got, the British examiner gave me unsatisfactory and the Indian examiner gave me borderline. And for only 1 mark, I missed the pass mark at that attempt. So from that situation, I got to know that in the UK, pulmonary embolism is a very much common case. So whenever the pulmonary embolism is the diagnosis, we have to tell it at the first differential diagnosis. Is it clear to everyone? This is a must to know for all the candidates, because chest pain is a very much common prompt in the PACES exam. This is a triple star prompt. Whenever chest pain comes in the PACES exam, in more than 90% of the cases, it is pulmonary embolism. And in that case, we have to tell the pulmonary embolism as number 1 differential diagnosis, not as number 2 or 3. If we tell say it at number 2 or 3, we are going to lose the mark for the shoe. Then come to the clinical
So
judgment.
even if there is a, sorry,
Yeah.
I'm going to ask, hello?
Yes, doctor?
Even if there is no clinical signs of leg swelling.
There will
and,
not be any clinical sign for 100%. This will be a dummy case because there is a pattern in the PACES exam that they will not keep any acute case. Pulmonary embolism is an acute case, so it will never be given in the PACES exam. They try to keep the case which are stable, and whenever they try to simulate some case, they will bring the dummy patient. Like many of you spend some taking preparation for like pyoderma gangrenosum, like bullous pemphigoid. But believe me, this case has never come in the PACES exam. Why? Because these are very infectious prone. And in the PACES exam center, they will not keep such case, which are very much critical. The bullous pemphigoid lesion can rupture anytime and it can disseminate. So they tried not to keep such case. The pyoderma gangrenosum case is an open case. So there's a chance of infection. So they will never keep such case. They keep that case that is stable. And whenever they are not able to bring the acute case, they will bring the dummy case. That happens maximum time. That pulmonary embolism, in 100% cases, you will get the dummy case. This is for sure. For hematemesis, they usually keep the dummy case. For loose motion, they usually keep the dummy case. This happens for every center, every case. That is why you have to know what type of case can be given to you. For part 1 and part 2 exam, you have learned about a lot of clinical scenario. I have learned about a lot of cases, but most of them are not PACES exam cases. That is the thing from this course we are trying to provide to the candidate, that what type of cases come in the PACES exam for the long clinical consultation. Then come to the clinical judgment. So for the clinical judgment, 2 types of questions are asked. One is investigation, another one is management. So after you complete the examination and meet the consent, and the 50 minutes is off, the examiner is going to ask you 4 questions. First question, do you have any diagnosis or differential diagnosis? To give you a mark in the differential diagnosis section. Second question is, what are your positive physical signs? To give you a mark in the identifying physical sign. Then the next question will be how you are going to investigate. Then the 4th question will be how you are going to manage. After you complete this answer, you will confirm your full mark. And what happens, sometimes some candidates are very much smart. They give all the answer in one go. So what happens in the PACES exam, there are 5 minutes time. If you are able to tell the investigation and management in a proper way, you are likely to get the satisfactory mark. But until the time is left, the examiner is going to ask you more and more questions. They can take you anywhere from research article to something like that. But these will not cost any mark to you. So from my suggestion will be not to give every answer in one go. Rather keep it something inside your tummy to let the examiner ask some question. How to do it, I will guide you for each case. Like in the investigation and management, we are going to provide the recording of investigation and management for each case separately. That is the more than 250 cases. And in the exam center, you have to tell like this. Like in the investigation, apart from basic investigation, we have to do investigation to confirm the diagnosis. Then we have to do investigation to find out the cause. Then we have to do investigation to rule out the complication. Last, to find out the association. In this way, you have to give answer. Then in the management section, in the PACES exam, there are 2 types of cases come. One is acute case and another one is stable case. So for the acute case, we have to start from saying that admission, then management of airway, breathing, circulation. After that, you can go for education and counseling, forming a multidisciplinary team, and treatment of the underlying cause. After that, treatment of the complication. So every time we have to start from admission and management of airway, breathing, and circulation. And believe me, Many candidates make this small mistake. They don't tell the management of airway, breathing, and circulation that the examiner want to hear. They again repeatedly ask, are you happy with the vitals of this gentleman? Just want to hear whether you are managing the airway, managing the breathing, managing the circulation, whether you are stabilizing the patient. This is the very much important thing to tell to the examiner. And whenever there is a stable case, we have to start from the education and counseling, forming a multidisciplinary team, then treatment of the underlying cause, then treatment of the complication. And for the management, I will suggest everyone not to give all the answer in one go. Suppose, sometimes there are multiple differential diagnoses, like loose motion. The cause of acute loose motion can be infection, can be IBD flare-up, can be malignancy. So during telling the management, treatment of the underlying cause. After that, I have to pause. After that, the examiner will ask you, suppose the underlying cause is IBD, what will be management? Then suppose the underlying cause is infection, what will be management? Try to let the examiner to invite some question so that you can kill some time. Otherwise, the examiner will ask you many questions, although it will not affect your mark in the clinical judgment if you are able to tell the investigation and management in an organized and professional way. But what happens in the exam? If you are not able to give all the answer, this will create a mental pressure inside your brain, and this can affect your next station. To avoid this, my suggestion will be, it is for all the station, not to give all the answer in one go. Try to give some indirect answer so that the examiner can invite something from you. This is a trick to kill some time in my sentence. Then managing patient concern is another skill. For managing patient concern, you have to keep at least 2 minutes. Whenever the examiner tells you that 2 minutes left, after 30 minutes, we have to keep this 2 minutes whole to manage the concern, because sometimes there are 5 to 6 concerns. And we have to manage this concern using not jargon, not using any jargon. We have to explain it in simple way. And this is very much simple. I will guide you during the course. And maintaining patient welfare is very much easy. If you are very much sympathetic, if you do the hand wash, and after doing the examination, if you help the patient to wear his gown again, you would get automatically full mark here. And almost no one loses mark here. And this patient welfare section is very much sensitive, because what happens, the pass mark is 28 out of 32 in this welfare section. And if anyone gets less than 28, he will be not given any seat for sitting in the PCS exam in the next diet also. This is their rule. So try to be a little more professional during dealing the patient. Doing your hand wash, try to tell the patient that thank you very much, and do not touch unnecessary to the patient body. Whenever you are going to touch the patient, every time you have to take the permission that I'm sorry, I'm going to touch your face. Is that okay with you? And doing the fundoscopy, try to do the fundoscopy without touching the patient's head, because unnecessary touch will cause harm your mark in the welfare section. So in this way, each examiner is entitled to give 14 marks, and from both examiner, it will be 28. So for each skill, each examiner has 2 marks in hand. So for all the 7 skills, it is 14. So during practice with your participants, with your candidate partners from this group, I will guide everyone to practice using this mark sheet. So what you have to do, after I provide you all the PDF cases of musculoskeletal system today, and also the physical examination, investigation, and management for each cases, we have to go through each case separately. You have to make your own note. Then I will specify 5 cases or 6 cases for you. Your job is to practice it with other participants of the group of this course. Then then the other participants also have to do the same with you, and you both have to practice to make marking using the mark sheet. I will provide the PDF to all of you, and you have to practice to provide each other's mark using the mark sheet, so that it will be easier for you to know how the examiners think. Then at the next session, I will assess how you have done the homework. I will practice one-to-one with each one of you. And I will throw cases exactly from the list of cases that I have provided to you, exactly from the same things. And this is my guarantee that from these cases, it is more than 95% guarantee that you will get common. It is actually 100%, but I will not tell 100% because because sometimes some accident can happen. I can make you guarantee that it is more than 95% that you will get common from this case list. From this problem list and also from the 240 plus case list, you will get your case common. So this is all for the course structure and the introduction. And in the PDF, you will get another thing, that is the diabetic questionnaire. So during, if any time any diabetic question comes to you, you have to ask some important question. What are the important questions? I have written it, I have provided it in details. Like that, you have to ask the general question. Do you have any high blood pressure for how long? How it was diagnosed? What medication you are taking? Are you going to the eye doctor, kidney doctor, foot doctor? May I know a 3 months blood sugar report? Then you have to assess the compliance in the form of triple D. That is diet, drug, and daily exercise. Then you have to rule out the complication in a high blood sugar coma or low blood sugar coma. Then you have to assess the microvascular complication, macrovascular complication, and autonomic complication. How to rule it out? This is provided in the PDF, and you will get it. Then this is the sequence of question of rheumatological screening. Whenever you will get any positive rheumatological symptom, you have to ask this sequence of question starting from the hand. Like any change in color of the finger upon exposure to the cold. I think this will be better if we discuss the prompt, because this is there today in the musculoskeletal and rheumatological system. So this is all about the course structure and the introduction. Please ask me any question if anyone have any kind of question, concern about the course structure, and any other question you have. Please feel free to ask me.
Can we get this PDF, whatever you've made?
Yes, everyone, every active participants will get this PDF. This will be provided there. One participants have asked, will you cover the communication scenarios? Actually not. This course is solely for the long clinical consultation. And I have tried from myself best to cover all that you need to pass the long clinical consultation in this one course. This course will cover more than 250 plus cases. Also, we'll teach you first the approach to individual prompt. Then we'll make you practice. Also, at the same time, during this course period, you have to do regular practice with your partner, and you have to keep the feedback to me daily. This is like something like homework. So if it is okay, then we are going to discuss today's class session, that is musculoskeletal system. So before that, I would like to take some 2 minutes break, but what I'm going to discuss for musculoskeletal system, I'm going to tell you. So these are basically the prompts that come from the musculoskeletal system. And I can guarantee you, you will not find any other prompt from these prompts from the musculoskeletal and also the rheumatological system. And these are the prompts that are coming in the last 3.5 years. So from the prompts, I have divided them into 3 sections. One is triple ester, another one is double ester, and another one is 1-ester. So what does that signifies? The triple ester prompts are the most important one. If you look the recent diet case questions that are publishing in many groups, you'll find that these are the triple ester cases that are coming very often. Then the double ester cases are medium important, and the least important are the 1-ester. So what I'm going to do right now, I'm going to discuss the approach to each prompt individually. What are the initial questions we have to ask? What are the differential diagnoses we have to ask? And how to screen for each differential diagnosis? Then what are the important physical examinations we have to do? So in this way, we are going to discuss these 8 prompts in today's class. I hope this is clear to everyone. So Okay. So if it is okay, and then I'd like to take 1-2 minutes break. After that, we are going to start discussing the musculoskeletal system, starting from the hand pain. So let's take 2 minutes break.
Flashlight leukemia interventions movement is the wider conflict is far from over. Soon, reflecting
So we are back again. Am I audible to everyone? If it is okay, then we are entering into the main section of our class today. So our first prompt will be the hand pain. So in the PACES exam, basically hand pains come over 5 differential diagnoses. That is joint pain, Raynaud's phenomenon, or carpal tunnel syndrome, or Takayasu arteritis, or AV fistula. Apart from these 5 things, never ever any joint pain has come and will come. Sometimes someone discuss about hypocalcemia, but in the last 3.5 years, I have not found any case where hypocalcemia is coming with the hand pain. So whenever any hand pain comes in the PACES exam, this is for sure. It will be either due to joint pain, or it will be due to Raynaud's phenomenon, or it will be due to carpal tunnel syndrome.
पर आप ताको उसको मैं जान उसको मैंने बहुत दफा देखा वो मेरा जूनियर है वो ये सारे मुझसे जूनियर हैं
I think
लेकिन बस ये आगे हम
someone is
पीछे रह कर
talking.
ये आगे निकल गए बस ये अपने लाइन पे चलते गए
I would request to mute. If sound is
तो अब
coming.
इनको फेस करते हुए जरा अजीब लगता है ये जूनियर्स को आप पैसे खनून होगा
Please mute yourself, doctor. Some sound is coming. Hello. Okay. Sorry for the disturb. So in the if hand pain comes, there are in the PACES exam, these will be either this from any of these 5 differential diagnoses. So our first question will be, what do you mean by hand pain exactly? Is it joint pain, or is it color change on exposure to the cold? That is Raynaud's phenomenon. Or is it tingling and numbness relieved by shaking and cold water? That is carpal tunnel syndrome. Or is it pain at hand while doing some activity? That is Takasu arteritis. We have to specifically ask this question, that what do you mean by hand pain exactly? We have to give some example, that is it joint pain? Is it color change? Is it tingling and numbness? Is it pain at hand while doing some activity? Or do you have any past medical condition? Do you undergo dialysis? That is AV fistula. So our first question will be, what do you mean by hand pain exactly? Is it joint pain, or is it color change, or is it tingling and numbness? That is carpal tunnel syndrome. Or is it pain at hand while doing some activity? That is Takasu arteritis. Or do you have any past medical conditions that I should be aware of? Do you undergo dialysis? That is to rule out AV fistula. After that, the next question will be analyzing the symptom using the mnemonic OD-para. That is onset. How did the symptom started? Did it started suddenly or gradually? Then for how long you are having this symptom? Then for I, is it the first time you are having this kind of problem? Then P goes for progression. Do you think your problem is gradually worsening day by day? Then A goes for aggravating factor, R goes for relieving factor. Have you noticed anything increase or decrease your symptom? So this goes for OD-para. After asking the OD-para, we have to go for LICOR. So L goes for location. Can you please show me the site of your pain? This is a must-ask question. Then I goes for intensity. Can you please grade your pain? 1 being the lowest and 10 being the highest. Q goes for quality. You have to ask about the specific quality of the pain. What is the nature of the pain? Is it dull or is it sharp? Then radiation. Have you noticed after arising, this pain goes to elsewhere? So in this way, you have to ask about LICOR. So I'm telling again, whenever in the PACES exam, any hand pain prompts come, this is likely due to be from these 5 differential diagnoses. This is 100% guarantee. So how to find the diagnosis? The first question will be, what do you mean by hand pain exactly? Is it joint pain, or is it color change, or is it tingling and numbness that is relieved by shaking and cold water, or is it pain at hand while doing some activity that is Takasu arteritis? To rule out AV fistula, we have to ask about the past medical condition, whether he undergoes any dialysis. Then we have to analyze the hand pain using the mnemonic OD-para. Onset, duration, whether it is the initial period, then progression, then aggravating factor, relieving factor, then LICOR. LICOR goes for location, intensity, quality, and radiation. After that, let's come to specific problem. That is, if it is a case of joint pain. Suppose the patient is telling you, yes, my hand pain is due to joint pain. So what will be the next approach? Next approach will be, we have to ask about the morning stiffness. We have to ask, do you have any morning jamming? If the patient replies you, yes, I have morning jamming, the next question will be, for how long? We have to see whether it is more than 30 minutes or less than 30 minutes to identify inflammatory versus mechanical back pain. Then the next question will be any other joint pain. After asking these 2 questions, we can directly go to the differential diagnosis of joint pain. So what are the differential diagnoses of hand pain that is due to joint pain? If the morning stiffness is positive, there are 3 differential diagnoses, either psoriatic arthritis, rheumatoid arthritis, or SLE. If the morning stiffness is negative, then this is due to mechanical. For PACES exam, the 2 differential diagnoses you need to know is gout and osteoarthritis. And each of these cases has come in the PACES exam. For psoriatic arthritis, we have to ask, do you have any rash? And we have, during physical examination, we have to search for every possible area of psoriatic rash. What are the possible area? Starting from the nail, we have to check for nail pitting. Then we have to check at the knuckle. Then we have to check at the elbow. Then back of the hair. Then we have to offer to the examiner that I want to do full skin exposure, looking for any skin rash. What are the possible area? The possible areas are axilla, underneath the breast, around the navel, and at the groin. Also, at the last, we have to check the knee joint. So what happened one time in Delhi that the patient was having psoriatic rash at the knee joint, and he was wearing a gown, and the candidate did not lift up the gown, and he missed the rash. So he lost his mark at that point. So I'm telling again the differential diagnosis. To rule out psoriatic arthritis, we have to ask, do you have any rash? To rule out rheumatoid arthritis, we have to ask any other joint pain. If the patient has symmetrical joint pain and morning stiffness, then this can be rheumatoid arthritis. To rule out SLE, we have to ask, do you have any skin rash or any rash after going to the sun? Do you have any mouth sore? So these 3 questions have to be asked. Any skin, any facial rash, any rash after going to the sun, then any mouth sore. These are the questions to rule out your differential diagnosis. So these are the screening questions for the inflammatory hand pain. Then for the non-inflammatory hand pain, that is mechanical pain, one is gout and another one is osteoarthritis. So it has come in the PACES exam. The osteoarthritis has come in the PACES exam, looking the Habermas, there was Habermas prominent at the patient's hand. Then how to rule out gout? To rule out gout, there is specific mnemonic. What is the mnemonic? I'm telling you. The mnemonic is DHL plus psoriasis. So here D goes for D3. One is diet, another D is drug, that is thiazide diuretics, another D is defect in kidney function. So you have to ask about the diet. What about the diet? Do you take excess protein like meat or seafood? You have to take the drug history, whether he is taking any thiazide diuretics, whether there is any defect in kidney function in the history. We have to look for that. The H goes for 5H. These H are the components of metabolic syndrome. That is history of high blood pressure, history of high blood sugar, history of dyslipidemia, history of excess alcohol, and history of smoking. Whenever anyone has metabolic syndrome, he is likely to have, he is at increased risk of having gout. L goes for lymphoproliferative and myeloproliferative disorder. To rule it out, just ask the triple L. That is loss of weight, loss of appetite, lumps and bumps in the body. Then the last cause is psoriasis. So by asking these questions, you can rule out gout. This is the mnemonic to rule out gout. That is D3HL plus psoriasis. Let's come to the differential diagnosis of joint pain. So suppose whenever you have got some positive symptom of inflammatory joint pain due to rheumatoid arthritis and SLE, at that time, you have to ask all the rheumatological questions. What are the rheumatological questions? These are the sets of rheumatological questions that I showed you earlier. Starting from the finger, we have to ask any change in the color of fingers upon exposure to the cold. That is to rule out Raynaud's phenomenon. That can occur in any case of rheumatological disease. Then we have to ask any joint pain and stiffness. We have to ask any skin thickening. That can occur in case of systemic sclerosis. Then we have to ask any difficulty in raising the arm or getting up from the chair to rule out polymyositis or dermatomyositis. Any hair fall. Hair fall can occur in case of discrete lupus erythematosus. That is carrying alopecia. And if the patient replies you that, yes, I have hair fall, then you have to look at the hair, you have to look at the head, removing the hair. Okay, one can ask why skin thickening. Skin thickening is there to rule out systemic sclerosis. This is a very much common case in the PACES exam. Any skin thickening. Skin thickening is there to rule out systemic sclerosis. Then at the eye, we have to ask any grittiness. Sorry. The connection was lost. Sorry. Then we have to ask any grittiness of eyes or mouth to rule out Sjogren's syndrome. This Sjogren's syndrome can be primary or secondary. These are the sets of questions of rheumatological system. Then we have to ask any skin rash, any rash at face after going to the sun. Then at the mouth, we have to ask about any mouth sore. This mouth sore can be there in case of SLE, also in case of mixed connective tissue disease. Then any chest pain, cough, to rule out pleuritis and pericarditis, also ILD, because SLE and some mixed connective tissue disease can affect the pleura and also the peritoneum, the serosal layer. To exclude the serositis or peritonitis, we have to ask any tummy pain. And in any case of rheumatological disease, this can affect the kidney. So we have to rule out any kidney involvement, asking the question, any change in the urine. We have to ask about the amount, color, frequency, and frothiness. So whenever in the history you are getting any clue that there can be any rheumatological component, we have to ask these questions, each one specifically. These are the 12 questions total. I will suggest to everyone to memorize these sets of questions so that it will be easier for you to ask these sets of questions. So this is for the morning stiffness positive joint pain, that is inflammatory small hand pain. And for gout, we have to ask about D3HL plus psoriasis. And in the osteoarthritis, we have to ask about the profession of the patient. And it will be evident from seeing the patient whether it is osteoarthritis or not, because typically the patient will have Habermas node or Butcher's node. And these are the cases given during practice session. You will get this case. So these are the differential diagnosis for joint pain. The next thing is Raynaud's phenomenon. So if the patient tells you that, yes, I have some color change after exposure to the cold, then you are making it confirm that this is Raynaud's phenomenon. The second question will be to know the stage of color change. So you have to ask whether it turns white, then blue, and then red. That indicates, white indicates ischemia, blue indicates stasis, and red indicates reperfusion. So we have to specifically ask the stages of color change of Raynaud's phenomenon. After asking this, we have to ask the sets of rheumatological questions. Why? Because in the PACES exam, Raynaud's phenomenon most often comes on background of systemic sclerosis or mixed connective tissue disease. SLE comes very less often. So these three differential diagnoses can be ruled out by asking these sets of rheumatological screening questions. I am telling it once again, any change in color of finger upon exposure to the cold, that is Raynaud's phenomenon. Any joint pain, stiffness, any skin thickening, any difficulty in raising the arm or getting up from the chair, any hair fall, any grittiness of eyes and mouth, any eye redness, any pain at eyes, any skin rash, any face rash at face after going to the sun, any mouth sore, any chest pain, any tummy pain, any change in the urine. These are the sets of questions you have to ask for if the case is Raynaud's phenomenon. So the second differential diagnosis is gone. Now let's come to the carpal tunnel syndrome. If the patient tells you that, yes, it is tingling and numbness relieved by shaking and cold water, then this is carpal tunnel syndrome. So what are the causes of carpal tunnel syndrome? In the PACES exam, in 100% of the cases, the carpal tunnel syndrome will be due to any weight gain. So you have to analyze the weight gain there. After you get that, the patient is telling you that, yes, my hand pain is due to tingling and numbness, which is relieved by shaking and cold water. Then this is carpal tunnel syndrome. Then after doing the Odipara and liquor, we have to ask about the weight gain. We have to ask whether it was intentional or unintentional, and how much has he put over how long. Then the differential diagnosis will be dependent whether it was localized weight gain or whether it was generalized weight gain. If it is localized, like more in the hands and feet, then it is acromegaly. If it is central part of the body, like the face, back of the neck, and the tummy, then this is Cushing syndrome. And if the weight gain is generalized, then the differential diagnosis is hypothyroidism, polycystic ovarian syndrome, and obesity due to overeating. And this is one of the most important PACES exam cases. This is coming again and again, and also in this diet, in many centers, like in the Chennai, in the Delhi, you will get these cases coming. That is carpal tunnel syndrome. And the cause of carpal tunnel syndrome is due to the weight gain. Either it is localized or due to generalized. Is it clear to everyone? Because this is a very much important case for PACES exam. Then, another important thing, whenever there is any weight gain in the PACES exam, we have to rule out 3 complications. So what are the 3 complications? One complication is carpal tunnel syndrome. That is the case here. Another complication is obstructive sleep apnea. Third complication is osteoarthritis of the knee and the lower back. So in the history, we have to ask this complication, whether there is any history of mouth sore, whether the partner complains of mouth sore, whether there is any joint pain. And these will be guided to you in the physical examination section. I will give you the recording. So you have to know that whenever there is any weight gain, we have to rule out carpal tunnel syndrome, obstructive sleep apnea, and osteoarthritis for any case of weight gain. And these are the simple things that many candidates miss and miss the diagnosis and miss the mark. It is not that that candidate cannot make the diagnosis. Most of the candidates can miss the diagnosis at the exam center, but they lose mark in small sections. So these are the small sections. Another important thing is, whenever, can anyone tell me what is the cause differential diagnosis of bilateral carpal tunnel syndrome? Can anyone reply it? What can you think for the differential diagnosis of bilateral carpal tunnel syndrome? Because this is a very important thing to answer. That is why I'm asking this question. No motor neuron disease. That is no acromegaly. I'm telling it, whenever a bilateral carpal tunnel syndrome case is given to you, what is the diagnosis? Cervical myelopathy. The diagnosis is cervical myelopathy. Why this is important? This thing has happened in the Dhaka center. The case was a bilateral carpal tunnel syndrome, but the candidate did not examine the chart of both upper limb to rule out cervical myelopathy. I'm again telling you, during doing physical examination, we have to do the examination of the carpal tunnel, confirming the carpal tunnel syndrome. But also, we have to check the chart, especially the Hoffman chart and supinator chart. Also, we have to check the biceps and tricep charts. Why this chart is important? Because one of the most important differential diagnosis of carpal tunnel syndrome is cervical compressive myelopathy. So to rule it out, we have to check the chart, and maximum candidate did not check the chart at that exam. I don't know, it happens sometimes in the basis exam, and they lost their mark in the physical examination section. So I'm telling it once again, in the physical examination, if you confirm your physical examination section, like confirm my diagnosis and ruling out differential diagnosis, find out the cause, find out the complication, ruling out the association, then it is unlikely that you will miss any part of the physical examination needed to get full mark. So whenever any bilateral carpal tunnel syndrome comes in the basis exam, never forget to check for the chart of both upper limb. This is to rule out bilateral cervical compressive myelopathy. So this is for carpal tunnel syndrome, and this is one of the most important cause, one of the most important prompt for basis exam. This will come again and again, and this has come, and this is coming. And in the basis exam, acromegaly, Cushing, hypothyroidism, PCOS, and obesity due to overeating, all of the prompts have come. I will discuss with you. After discussing 3 prompts, I will throw real basis exam case scenarios to the candidates right now, and I will see who can answer the questions. Okay, what is the specific question of carpal tunnel syndrome? The specific question was discussed earlier. The specific question is it tingling and numbness relieved by shaking and cold water? This is a specific question for carpal tunnel syndrome. Whenever any hand pain comes in the basis exam, we have to ask, what do you mean by hand pain exactly? After that, you have to give some example. Is it joint pain? Is it color change? Is it tingling and numbness? Or is it pain at hand while doing some activity? All of the differential diagnosis has come in the basis exam. Okay, then let's come to the Takasu arthritis. Takasu arthritis has come in the Kolkata and also in the UK with the prompt of hand pain. So what happens in the Takasu arthritis? The patient will tell you that yes, after doing some hand activity, some activity with my hand, I'm feeling some pain. So what is important? You have to analyze the symptom using the Odipara and liquor. After that, we have to ask the systemic questions. PDF subject, we have to complete the format. There are no other differential diagnoses for this Takasu arthritis. What is important for Takasu arthritis is that we have to check for all the pulse, including the radial pulse, femoral pulse, all the pulse. We have to check for the radial delay. We have to check for the radiofemoral delay. And also, we have to check for each bruit, like the carotid bruit, subclavian bruit, also the renal bruit. But here, lower limb examination can be omitted. Why it can be omitted? Because, sorry, my charge is down. Why it can be omitted? Because Takasu arteritis is less likely to affect the lower limb. That is why it can be omitted to examine the lower limb. So I'm sorry, my charge is down. I have to do some charging and I'm coming back 1 minute later. Please give me some time. Okay, let me make once again. So what is important in case of Takasu arteritis? We have to check for each pulse and breathe. We have to check for each radial delay and radiofemoral delay. And it is not necessary to examine the lower limb. So what happened for one candidate in the Kolkata center, he did not examine the lower limb. He got a case of Takasu arteritis, the prompt was hand pain. So the examiner asked him, why did not you examine the lower limb? The candidate replied that usually the Takasu arteritis affects the arch of aorta, the branches of the arch of aorta. So less likely to affect the lower limb. And he got the full mark. So this is the important thing you have to keep in mind during Takasu arteritis. And these cases come in Kolkata and also in the UK. The next case is AV fistula. It will be evident from the past medical history that the patient is having some AV fistula. So this is a very much common case in the Delhi center. This is coming every now and then, and although today these cases come. So what is the cause of AV fistula? Pain. The cause can be either due to blocked AV fistula, it can be due to ischemic steal syndrome, or it can be due to any local infection. In case of ischemic steal syndrome, what happens? The blood is diverted to the proximal circulation. And the distal hand can getting less circulation. So we have to feel for the temperature at the hand. If there is ischemic steal syndrome, the hand will be pale and cold. Then it can be local infection. We have to feel over the AV fistula, looking for any increased temperature or we have to see for any redness there, indicating infected AV fistula. So these are the three causes of AV fistula pain. And whenever any hand pain comes to the PCS exam, we have to check for the functional capacities of the hand. And this is the most common thing that most of the candidates forgets to examine. And if you don't do the functional capacities of the hand, you are likely to get loss in mark. It is for 100 shield. And where you lose your mark, you will lose your mark in the physical examination section. So how to check the functional capacities of the hand? You just do two things. One, you have to tell the examiner, you have to tell the patient, can you make a fist and open it for me? The next thing is, you have to tell the patient, can you please button and unbutton your crown for me? These two ways, you are checking the functional capacities of the hand. And I'm telling, this is the important thing that most of the candidates forget to examine. Whenever any hand pains come, they forget to examine for the functional capacities of hand. So this is all for hand pain. Please tell me if anyone have any kind of question.
Sorry, can you please tell me again that how to differentiate between the ischemic steal syndrome and blocked AV fistula?
Okay. In case of ischemic steal syndrome, what actually happens? In case of ischemic steal syndrome, blood actually diverts through the fistula. So the distal circulation, distal part of the hand don't get enough blood circulation. So it will become cold and pale. And block AV fistula occurs due to some blocking, like due to some thrombus or due to some embolus into the fistula. So we have to examine the fistula. How to examine the fistula? First, from the inspection, we have to check for any redness. If there is any redness, it indicates local infection. If there is any pinch mark, it indicates it has been used recently. Then we have to feel for the temperature. If the temperature is raised, then it indicates infection. Then we have to feel for the bruit. If the bruit is absent, then it indicates this AV fistula is blocked. Then we have to hear for bruit. We have to feel for 3 and we have to hear for bruit. During hearing, if we don't find any bruit, that indicates the AV fistula is blocked. Is it clear, Dr. Shubhadeep?
Yes, thank you.
Okay, doctor.
Then, so
Yeah.
blocked AV fistula usually happens when the AV fistula is not being used for long time.
Yeah, that can
So-
happen.
So why does it cause hand pain in that case? Well, I'm
Because
just trying to understand.
why? Because the blood circulation, I think it is not clear to me, but blocked AV fistula can cause some local infection. That local infection can cause some pain.
Okay.
Okay. So please ask me anyone. I'm going to take 30-second, 10-second time to invite question. If anyone have any question regarding the approach to joint pain, if it is clear, please give me a thumbs up in the reaction section. Then I can proceed to the next case. Okay, let me go to the next case. That is next prompt. That is low back pain. It is also very much common prompt coming in the PCS exam. It comes very often. That is why it is a triple star case. Hand pain is one triple star case, and low back pain is another triple star prompt. Sorry for telling this case. It is a prompt. So whenever any pain comes, we have to localize the site. Why this is important, I've already told you during discussion of the introduction. What happened at one time at Pondicherry, the prompt was low back pain. So after entering the station, whenever the candidate asked, can you please show me the site? The candidate typically showed her, instead of showing his lower back, he was showing the renal region, lumbar region. So that was basically a case of pyelonephritis. That was not a musculoskeletal case. That is why identifying the site of pain is very much important. So how to approach to a low back pain of musculoskeletal cause? Our first question will be whether you are having any morning jamming. And if there is a morning jamming, we have to ask about the duration. For how long? We have to see whether it is more than 30 minutes or less than 30 minutes. Then we have to analyze the symptom using the mnemonic OD-para. O goes for onset, D goes for duration. For how O goes for onset, how did the symptom started? D goes for duration, for how long you are having this symptom. I goes for initial episode, whether this is the first time you are having this kind of problem. P goes for progression. We have to ask, is the pain gradually increasing or decreasing day by day? Then A and R goes for aggravating factor and relieving factor. We have to ask, have you noticed anything increase or decrease of symptom? Then we have to analyze it using the mnemonic LICOT, that is location, intensity, quality, and radiation. We have to identify the site of the pain. We have to identify the intensity of the pain. We have to tell the patient 1 being the lowest, 10 being the highest. How will you score it? Then Q goes for character. What is the nature of the pain? Is it dull or sharp? We have to give some example. Then R goes for radiation. Have you noticed the pain goes anywhere else? Then the fourth thing will be to rule out any red flag sign for low back pain. We have to do this must. So what are the red flag signs? The red flag signs is the first, any weakness of lower limb, any change in sensation of lower limb, then any change in sensation around the private part. To rule out perianal anesthesia. The fourth question of any loss of bowel or bladder control. The fifth question will be, have this pain anytime wake you up at the night? This is a must-do question. This is night pain. The question will be, have this pain anytime wake you up from the night, from sleeping? Because night pain is a red flag sign, this indicates this pain can be due to malignancy or this pain can be due to an inflammatory cause. So for any low back pain, identify the red flag sign. You will not get any red flag sign in the PCS exam, but you have to ask this. And most of the candidates forgets to ask the red flag sign. And if you don't ask the red flag sign, you will lose your mark in the clinical communication skill for sure. So these are the screening question for any red flag sign. Then the next question will be, any other joint pain is there or not? Then we can directly go to the differential diagnosis. So what are the differential diagnoses? If there is morning stiffness positive, that the cause of back pain is inflammatory. If it is negative, that the cause is mechanical. So the inflammatory cause of back pain is the seronegative spondyloarthritis. They are ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and enteropathic arthritis. For the mechanical pain, it will be either due to trauma or septic arthritis or osteoporosis or osteoarthritis or metastasis, multiple myeloma, PLID, and psoas hematoma. I am telling what will be the screening question for each of the differential diagnoses. If the patient tells you that I am having morning jamming more than 30 minutes, then you can specifically ask the screening question of inflammatory back pain. At that time, no need to go for the screening question of mechanical back pain. This also happens in case of mechanical back pain. Whenever the patient tells you that I don't have any morning jamming, then you can directly ask the screening question for mechanical back pain. No need to ask the screening question for inflammatory back pain. So let's start the screening question. For ankylosing spondylitis, there is actually no screening question. This is actually diagnosis of exclusion. For psoriatic arthritis, we have to ask, do you have any skin rash? For reactive arthritis, we have to ask, whatever your water work or urine output, any pain during urination, any unusual discharge through your private part. I am sorry to ask you this private question. For enteropathic arthritis, we have to ask any loose motion, any blood in the motion, to rule out Crohn's disease and ulcerative colitis respectively. So these are the screening questions for inflammatory back pain. For mechanical back pain, for trauma, for any kind of mechanical back pain, we have to ask about the history of trauma. For septic arthritis, typically in the history, the patient will tell you that he is having some high temperature, he is having some loss of weight, loss of appetite, and also some fever, fatigue. So it is usually given in the PCS exam on the history of uncontrolled diabetes mellitus, and typically there will be a history of skin breaching, like the patient was walking in the garden and he got a scratch at his skin. Right now he has come with back pain. So what can be the cause of back pain in this case? Can anyone answer? I'm telling again, patient has back pain. In the past medical history, the patient has uncontrolled diabetes mellitus. Yeah, septic discitis. Wonderful, doctor. It is discitis. These are real PCS exam cases. Back pain also come this case does not come in the India and Bangladesh. That is brucellosis. In the past medical history, the patient has history of ingestion of unpasteurized cow milk or something like that, and the patient has come with low back pain. That is due to brucellosis, and it is common case in the Middle East, like the Sharjah, Dubai, but it does not come. The brucellosis does not come in the India and Bangladesh. Then osteoporosis. In the osteoporosis, typically in the history, the patient will give you any history of like steroid intake, either any history of steroid intake or loose motion due to celiac disease. That is causing osteoporosis. Also, in the past medical history, the patient can give you some history of taking anti-androgen. Patient is a diagnosed case of prostate cancer and he is taking anti-androgen. Right now, he is having back pain. That is due to osteoporosis. So these are the type of cases that comes in the PCS exam. Almost always, there will be a clue in the past medical history. or osteoporosis. Either the patient is taking some steroid, or the patient is a diagnosed case of celiac disease, or the patient is taking some anti-androgen for prostate cancer. Then osteoarthritis will automatically come in the differential diagnosis of any case of low back pain. Then coming to the metastasis. For the metastasis, that patient will typically feel the pain. The pain will typically rise her from the sleep in the night. That is a late wake sign. And in the past medical history, the patient can give you some history of breast cancer 5 years back or 10 years back. The patient can give you some history of prostate cancer that occurred 7 years back. Now the patient has come with low back pain that is mechanical. So metastasis will be a differential diagnosis. In case of multiple myeloma, to rule it out, the mnemonic is CREB. Here C goes for hypercalcemia, R goes for renal deformity, A goes for anemia, B goes for bone pain. So we have to ask about the symptoms of hypercalcemia. That is polyuria, polydipsia. We have to ask, do you feel increased thirst? Or what about water work? Do you have increased water work? Just by asking the hypercalcemia question, we can rule out the multiple myeloma. No need to ask other questions. It is for the screening purpose. Then PLID, you can typically keep this differential diagnosis for any cause of low back pain. Then the last was psoas hamartoma. This has come in the PCS exam with the background history of mitral valve replacement with the history of taking warfarin. So are you seeing why the PDF is so much important? You'll automatically get a clue in the PDF in more than 80% of the cases. The patient is a case of, what is the hint for infective discitis? Okay, doctor, I'm coming. So in the psoas hamartoma, if the patient is a case of mitral valve replacement or aortic valve replacement, and the patient is taking warfarin. Right now, the patient is having low back pain. So the pain is likely due to some psoas hamartoma. In that case, we have to look for any triggering factor or increased warfarin effect. In the history, there will be likely a history of taking antibiotic. That is why the effect of warfarin has increased, and it is causing bleeding in the psoas muscle. That is causing psoas hamartoma. So this is all for mechanical back pain. And in case of mechanical back pain, we have to examine the gait must, and we have to examine the lower limb must. At least check the plantar, ruling out any compression. And these are the important things that many candidates miss. Not all the candidates, but many candidates miss to examine the gait, miss to examine the lower limb. Then they lose the mark in the physical examination section. Dr. Shubhadeep has asked any sign of psoas hamartoma on examination. No. In the exam, you will be given a dummy case. Dummy case in the sense of psoas hamartoma, not in the sense of mitral valve replacement. The patient will typically be a mitral valve replacement patient coming with low back pain, but he will not have any sign showing psoas hamartoma because this is an acute case. They will not keep any real psoas hamartoma patient in the exam. But in the skin, you have to look for any bleeding manifestation, like bruising, like any bleeding underneath the skin. You have to look that for. But likely that it will be a dummy patient. The patient will be a typical history of mitral valve replacement. You will get the click, but you will not get any signs of increased warfarinization. That easily occurs in the PCS exam. Is it clear, Dr. Shubhadeep? You asked me another question. What was your earlier question? What was the hint for infective discitis? Okay. Whenever in the PCS exam, any septic discitis come, in the history, there will be a history of entering the infection to the body. So if you can remember, the sets of questions in the past medical history, I have shown you in the PDF. I'm looking. So these are the sets of questions. In the question, if you see any recent infection or any recent procedure or any surgery, there will be another set of questions, that is any recent injury. So if in the history, the patient tells you that recently, 5 days back, while I was doing gardening, I got some hurt at my knee, at my leg. And right now the patient has come to you low back pain. then this is due to septic arthritis. So in the history, we have to ask for whether there is any history of skin breaching, whether there is any history of injury to the skin. Is it clear, Dr. Shubhadeep?
Yes, yes, thank you.
Okay.
And what is PLID?
Sorry. Doctor, your voice is breaking, doctor.
Hello, what is hello?
Yes, doctor, please tell it once again.
What is PLID? Sorry, I missed that part. I think.
Actually, PLID and osteoarthritis, these are the common differential diagnoses you can keep for any mechanical back pain. I've told you that you have to keep at least 3 differential diagnoses. So these are the common differential diagnoses. From the history, there is nothing there to rule out PLID. In the PLID, the patient can tell you that whenever I was lifting some heavy weight, at that time the pain started. This is a clue that the case is PLID. But typically, the case is not given alike. Are you getting my point, Dr. Shubhadeep? Or should I repeat once again?
No, yes, yes, okay. So prolapsed intervertebral disc, this PLID.
Yeah.
Okay.
You wanted to know the abbreviation. Okay, the abbreviation is prolapsed intervertebral disc. The patient
normally we
will,
say it's PIVD, so it's prolapsed lumbar intervertebral.
yeah, prolapsed lumbar intervertebral disc. So suppose you have been given a case of low back pain, that diagnosis is osteoporosis. So you have to tell the differential diagnosis is either due to PLID or osteoarthritis. You can keep all that mechanical causes of low back pain that is given in the list, but you have to tell what goes against each DD. Like in the PLID usually happens whenever the patient is lifting some heavy weight. At that time, the patient pain starts, and the pain is aggravated during sitting position. So from the history and physical examination, if you don't get something like that, you have to tell the examiner that PLID is unlikely because the pain did not start suddenly, and the pain is not increased during sitting posture. Is it clear, Dr. Shubhadeep?
Yes. Okay. Thank you.
Okay. And what are the crucial things that the maximum candidate means? That is examination of the gait and examination of the lower limb. So never forget to examine the lower limb, at least check for plantar. So this is all for low back pain. Do anyone have any kind of question from the low back pain? Please ask me. I will be happy to help you. Okay. It is clear, then I'm going to the next prompt. After that, I will like to invite some case to the candidates to see who can answer. So the next triple step prompt is knee pain. For knee pain, the same way, we have to start from the morning jabbing. Do you have any morning jabbing? If it is positive, we have to ask the duration, whether it is more than 30 minutes or less than 30 minutes. Then we have to ask about the Odipara. Then we have to ask about the Licor. Then we have to ask any other joint pain is there or not. Then based on the morning jamming, we have to differentiate the knee pain. If there is morning jamming, then the cause is inflammatory. If there is no morning jamming, the cause is mechanical. The mnemonic is here, ghost. So let's first come to the inflammatory knee pain. So the inflammatory causes of knee pain are either spondyloarthritis or rheumatoid arthritis. And the spondyloarthritis has 4: ankylosing spondylitis, psoriatic arthritis, enteropathic arthritis, and reactive arthritis. And how to rule out each differential diagnosis, the screening questions I have already discussed. So I'm not repeating it once again, how to rule out the differential diagnosis. Then if the cause is mechanical, the mnemonic is ghost. So what goes for ghost? G goes for gout and pseudo-gout. H goes for hemarthrosis. O goes for osteoarthritis. S goes for septic arthritis. And T goes for trauma. How to rule out gout? I've already discussed the mnemonic D3HL plus psoriasis. Here D goes for diet, drug, and defective kidney function. We have to ask about the diet, whether the patient takes excess seafood or meat product. We have to ask about the 5H, that is metabolic syndrome. History of high blood pressure, high blood sugar, high blood cholesterol, history of alcohol, history of smoking. Then we have to ask about the L, that is any lymphoproliferative or myeloproliferative disorder. To rule it out, just ask the triple L. So what goes for triple L? L goes for loss of weight, another L goes for loss of appetite, another L goes for lumps and bumps in the body. So by asking D3HL, and for psoriasis, we have to ask any skin rash there or not. We can rule out gout. For pseudo gout, in the PACES exam, hemochromatosis is important. It can be primary hemochromatosis or secondary hemochromatosis. So secondary hemochromatosis is due to repeated blood transfusion. And that the patient, if you enter into the room, you will find that the patient is a tan, and he has a history of repeated blood transfusion due to some congenital hemolytic anemia, and he is having some stigmata of CLD. But right now, he is complaining of knee pain, that is due to pseudogout. So you have to ask about the past medical history, whether he has been having any diagnosis earlier. If the patient tells you that, yes, I'm a case of hereditary sporocytosis, and I'm taking repeated blood. Right now, I have come with low pain at my knee joint. So that is the pseudogout. For PACES exam, only hemochromatosis come. Other causes of pseudogout does not come in the PACES exam for sure. Acromegaly does not come, hyperthyroidism does not come for the pseudogout. Only the hemochromatosis come. For the hemarthrosis, typically in the past medical history, the patient will give you some bleeding disorder. Like the patient can give you some history of hemophilia. The patient can tell you that I'm a diagnosed case of bleeding disorder. Sometimes the surrogate can tell you that I don't remember the name of the disease, but this is due to any bleeding. And my brother also has the same bleeding problem. So this is hemophilia, and right now the patient has come with joint pain, and this is due to hemarthrosis. For osteoarthritis, it is typically the patient will be older and postmenopausal. And on examination, you have to elicit crepitation. No other clue will be there. And this is a very much common case in the PACES exam. This comes every now and then, osteoarthritis with knee pain. This osteoarthritis can come with the prompt of fall also. I will discuss it during discussing the neuro prompts. So to rule out osteoarthritis, we just have to look at the age of the patient, whether the patient is aged or not, like 60 years and 65 years. Other than that, no other screening questions are there for osteoarthritis. For septic arthritis, typically, like the discitis, the patient will give you a history of skin breaching or history of recent procedure, like some intra-articular procedure. What happens in the PACES exam? It is given that the patient is a case of osteoarthritis, and she is taking intra-articular injection, that is steroid injection for that. And 7 days before, she took one intra-articular injection, but for right now, he has come with you with joint pain and fever. So this is a case of septic arthritis, and the route of infection, route of entry of the bug is the IV injection. That is why past medical history is that much important. We have to ask if there are any recent procedure. And what happens sometimes is all the time the surrogates are not that much helpful. Sometimes the surrogate will not reply you the specific answer until you ask the specific question. That is why you have to ask whether there is any recent procedure or not. And last goes for trauma. T goes for trauma. So this is to rule out the ghost. And Dr. Shubhadeep has asked, what are the diet question? The diet question, just ask the patient, what about your diet? Do you take excess protein diet, like excess seafood or meat product? Is it clear, Dr. Shubhadeep? Okay. So you have to know. Okay. So in this way, we have to know what will be the different, how to approach for each case separately, what differential diagnosis we have to think, how to rule out each differential diagnosis by asking for screening question for each, then you can proceed for the examination. So if it is okay, then for the knee pain, also we have to examine the gait. Any low back pain, any knee pain, any ankle pain, we have to examine the gait. This is to check the functional capacity. Sorry. So this is all for knee pain. Please tell me if anyone has any kind of question. If not, then I would like to invite some real PACES exam case scenario to all the candidates to see who can answer the question. Please give me a thumbs up if it is clear. Let's proceed. Now it will be an interactive session. Enough of study. Now to see how far have you understood. So right now I'm going to discuss some real basis exam cases that have appeared over the last 3.5 years. I'm going to ask you what will be the probable diagnosis. You have to ask, you can think for. Dr. Ashish has asked, protein is a jargon. No, protein is not a jargon for basis exam. Okay, let me ask you a question, give you a scenario. These are real basis exam scenario. So this was a case of 65-year-old male with low back pain. In the past medical history, he had a history of prostate cancer, for which in the drug history, he took chemotherapy. So what will, yeah,
Metastasis.
wonderful, doctor. Metastasis. Metastasis. Isn't that simple? Are you seeing how much simple is basis case? You just have to identify the diagnosis and ensure mark at each skill, like physical examination, identifying physical skill, clinical communication skill, then differential diagnosis, then clinical judgment. Let me ask you another question. Okay. A 35-year-old lady has come with low back pain. This pain is there for 1 month. Outside, the vital is given blood pressure 150 by 85. After entering the station, in the past medical history, you're finding that patient is a diagnosed case of bronchial asthma. And in the drug history, you're finding that she is taking steroid for last 3 months after recent flare-up.
Osteoporosis.
Osteoporosis.
Due to?
Steroid.
Steroid.
Wonderful. Osteoporosis due to steroid. Look how much simple is it. So here you have to examine the lower limb. You have to examine for the Cushing syndrome. And also you have to rule out the other differential diagnosis, other complications. Because in a case of Cushing syndrome, there will be a weight gain. And for any weight gain, what 3 complications we have to rule out? Can anyone tell me? I have told this. 3 complications for any. Wonderful. Then,
Ulcerative dyspnea, osteoarthritis.
yes, Dr. Sushmita is wonderful. Yes, Sushmita Apu. These are the whenever any weight gain, you have to rule out these 3 differential diagnoses. If you don't rule it out, you will lose your mark in the clinical communication skill. Also, if you don't do the physical examination for this, you will lose your mark in the physical examination skill. Then, let me tell you another question. Ask you another question. 35-year-old male with low back pain. He is giving history of loose motion for 3 weeks. And casual contact, that is unsafe sexual relation, 1 week ago. And this low back pain is inflammatory.
Reactive arthritis.
Yes, reactive arthritis is wonderful. You can keep all the other spondyloarthritis, seronegative spondyloarthritis in the differential section also. Yeah, you can rule out enteropathic arthritis also. So it is that much simple. Let me ask you another question. Okay, let me find out the case. Okay. Let me ask you some real this type question. The patient is complaining of hand pain. After entering the station, after asking what do you mean by hand pain exactly, he was telling it was some tingling and numbness at hands, with his little bit shaking, and submission in the cold water. Yes, this is carpal tunnel syndrome. So what is the next important question you have to ask for patients?
Weight.
Weight gain.
Wonderful, doctor. Weight gain. And the patient typically replied, yes, he has weight gain. So based on the weight, how can you differentiate?
Symmetrical
Hands
or
and acromegaly.
arithmetical.
Yes, localized or
Generalized.
generalized. So for this weight gain, what are the important complications you have to exclude also apart from this carpal tunnel syndrome?
Osteoarthritis or osteoarthritis.
Yes, OSA and osteoarthritis. It is that much simple. And whenever any bilateral carpal tunnel syndrome comes, usually bilateral carpal tunnel syndrome is given in the patient's exam. What is the important physical examination you should not miss?
Hoffman.
Reflection.
Sorry?
Reflex.
Yeah, reflex.
Reflex and Hoffman.
Yes, wonderful, doctor. These are the subtle things. These are very much simple things, but subtle things that a candidate miss and lose their mark. Okay. Let me ask you another question. You will be able to answer this question. That a 40-year-old male, this is the Delhi question, with hand pain. Yeah, Dr. B has asked, cervical myelopathy will have another sign also. Yes, cervical myelopathy will have another sign, but we have to do the examination to rule out the differential diagnosis. The case will not be cervical myelopathy. The case will be carpal tunnel syndrome. But we have to show to the examiner that we are ruling out cervical myelopathy also by checking the Hoffman sign. Also, supinator chart, and if possible, check the other charts also. So, this is the case, 40-year-old man with hand pain. In the past medical history, the patient is having CKD and AV fistula. So what is the cause of hand pain in this gentleman? These cases come today.
Blocking
Yeah.
AV fistula.
Anything
Blocking
else?
AV fistula.
Anything else?
And infected AV fistula infection.
Yes. Infection.
And ischemic steal syndrome.
Yes. Ischemic steal syndrome. It is that much simple. Okay. These are the real PACES exam cases that have come in the PACES exam. Okay. A 38-year-old male, old female. Yes, is Doppler needed? Yes, Doppler is needed. This will fall in the investigation section, whether Doppler is needed or not. We have to tell it in the investigation. So 30-year-old female has come with low back pain. And in the history, the patient is telling you that she is also having loose motion for the past 3 months. That is related to the gluten, like bread,
Celiac.
barley, yes, celiac disease.
Celiac osteoporosis due to celiac.
Yeah, osteoporosis leading to celiac. A 57-year-old man has come with severe low back pain. It is mechanical type. In the past medical history, the patient is telling that he has a history of mitral valve replacement. In the drug history, he is taking warfarin and needs an introduction of antibiotic for some sore throat. So what is the cause of low back pain?
Schwannomatoma.
Yes, pseudohematoma. It is that much simple. Okay, I have not told you another low back pain cause, that is low back pain in case of Marfan syndrome. Can anyone tell me? It also came in the PACES exam. It was a, let me find it, 25-year-old man with low back pain. It was a Marfan syndrome.
Dural ectasia.
Wonderful, doctor. Dural ectasia. Dural ectasia. Any other cause?
Maybe
Aortic-
there is some. No,
Aortic dissection cannot cause low back pain, doctor. One have answered. So what is the
And,
cause?
Hyperextensibility of the joint.
Yes. Now, osteoporosis usually does not occur in case of Marfan syndrome. Usually, it is occurring.
Hyperextensibility of the joint is maybe another cause.
Can be kyphosis or kyphoscoliosis.
Right.
And for this Marfan syndrome, we have to do specific examination starting from the hand. We have to check for the joint laxity. We have to check for the increased hand diameter. We have to check to do the wrist sign, thumb sign. All of the examination sequence are given in detail in the recording. So what you have to do, you have to go through the recording. You have to make your own note. What physical examination should I do if this case comes to the PACES exam? Then I will also give you the details of the PDF cases. Like, let me show you some example. So for musculoskeletal, there are about 30 cases. So suppose there is a case, all the details are given here. This is a case of joint pain. The patient has come in hand pain, and the cause of hand pain is osteoarthritis. You will be given a picture, and all the details are given here. So simulating the real PACES exam cases. So after getting the PDF case, you have to go through the physical examination video of each. In the physical examination, all the details of how to do the physical examination for each case will be given to you. You will be demonstrated. You have to do the chest. All the physical examination needed to do for each case separately. So you have to take your preparation, and during the next session, you have to practice one-to-one after taking preparation. And during this time, also you will be assigned with certain homework. Like you will be given 5 case or 6 case. You have what will be your job to make this practice with other active participants. And during the next session, I will assess your homework, what you have done. I will have one-to-one practice. How to get the PDF and videos. Okay, doctor, it will be given to all the active participants. Okay, if anyone is interested, please knock at the WhatsApp contact number after this session. I will be happy to help you then. Okay, so is this okay about these 3 triple star prompts? If it is okay, then I will proceed to the next prompt that are less important for the PACES exam. Please ask me if anyone have any kind of question regarding the first triple star prompts. That is the hand pain, low back pain, and knee pain. Do anyone have any kind of question? If it is okay, please keep me. Yeah.
I have one question. In case
Yes.
of buttoning and unbuttoning,
Yes.
in case of functional capacity, so if the patient is unrest and there's some there's a not availability of the buttoning and unbuttoning. So
At that time, you can check the. You will be given a pencil at your hand. You can just tell the patient,
Okay.
"Can you please hold the pen for me?"
Okay.
Take the pen and keep it there.
One
Just
is can you please grip and open your hand one, and
Yes.
then I can control. Can you please keep this pencil for me? I have a pencil in my hand.
Yes. One
Okay.
examination is enough, but doing 2 examination will keep you at the safe side. But these are the subtle things that many candidates do not do. For hand pain, we have to check the function and capacities of hand. For low back pain, we have to check the gait and examine the lower limb. For knee pain, we have to check, offer to check the gait. Yeah, at least check the plantar. These are the simple things that many candidates miss and lost the mark. Otherwise, this exam is very much doable exam. and very much easy exam.
But
Okay.
one question, suppose
Yeah.
in case of knee pain, the patient is diagnosed case of gout. Patient told that I have so much pain. When I asked about the gait,
Yes.
still I have so much pain, so I can move my leg.
Yes, exactly. Wonderful question, doctor. Wonderful. At that time, you have to offer to check the gout. You have to tell the examiner that I want to check I want to check the gait, but the patient is in pain. Should I proceed? Then the examiner will tell you that no need.
Okay. Thank you.
Okay, doctor. So right now I'm going to discuss the ankle pain, hip pain, and shoulder pain. And regarding the codes, if anyone have any kind of query, please feel free to ask me at my WhatsApp number. I will give you the details, the timings, duration, and all the details you need to know about the course. So again, my charge is lost. So give me 30 seconds. Okay, I'm back once again. Now, I'm going to discuss the approach to ankle pain. These are double staircase. So this is less important. So what are the double staircase? Okay, I'm telling you. The double staircase, one is ankle pain. So how to approach to ankle pain? First, we have to analyze the symptom using the mnemonic ODPARA. That is onset, duration, initial episode, progression, aggravating factor, relieving factor. I think all of you are acquainted with the ODPARA. Then we have to localize the pain, intensity, quality, and duration. Then we have to ask, is there any other joint pain? Then based on the morning jamming, we have to differentiate whether it is inflammatory or it is mechanical. It will be the same as the knee pain. If there is morning jamming positive, then it is spondyloarthritis, that is seronegative spondyloarthritis and rheumatoid arthritis. And if it is mechanical, then the mnemonic is ghost. So the screening question will be the same as the knee pain I have discussed. I hope this is clear to all. So I am not repeating it once again. And in case in this, sorry, where have come? And in case in this ankle pain, also we have to offer to check the gait. The patient will have pain and he will not be able to walk, but we have to offer to check. We have to tell the examiner that I want to check the gait. If it is possible? Then the examiner will tell you that no need. So this is all for ankle pain. Then come to the next prompt, that is shoulder pain. It is also a double step prompt. So how to approach to a shoulder pain? First, we have to check whether it is unilateral shoulder pain or bilateral shoulder pain. If it is unilateral shoulder pain, then the differential diagnosis for the PACES exam, adhesive capsulitis. I'm telling you, for the PACES exam, the differential diagnosis for unilateral shoulder pain is adhesive capsulitis. For telling the differential diagnosis of adhesive capsulitis, you can tell supraspinous tendinitis or osteoarthritis. For bilateral shoulder pain, the differential diagnosis is polymyalgia rheumatica or polymyositis for PACES exam. I'm telling you, these are the differential diagnoses for PACES. Now, avascular necrosis, you can tell it for adhesive capsulitis differential diagnosis. But up to now, no avascular necrosis has come as the shoulder pain up to now. You can tell it in the differential diagnosis because in the avascular necrosis, there will be typically a history of steroid intake or alcohol intake or some sickle cell history. So you can keep it in the differential diagnosis of adhesive capsulitis. But the primary diagnosis will be adhesive capsulitis due to uncontrolled diabetes. And if it is bilateral joint pain, that is bilateral shoulder pain, the diagnosis will be either polymyalgia rheumatica or polymyositis for PACES exam. In real life, you will get many other cases, but for PACES exam, these are the two important differential diagnoses. This has come in the Sharjah Center. In the Middle East Sharjah Center, the prompt was an old age lady having shoulder pain. After entering the station, it was found that that was bilateral shoulder pain. So what you have to do after analyzing the symptom, Odipara, then Licor, then any other joint pain, you have to ask whether there is any morning jamming or not. If there is morning jamming with shoulder pain, then this is polymyalgia rheumatica. If there is no morning jamming but weakness with shoulder pain, then this is polymyositis. This is that much simple. And in case of polymyalgia rheumatica, also rule out giant cell arteritis. So you have to ask whether there is any pain at the head, at one side of the head. Then the next double star case is hip pain. Here, for the hip pain, it is also a double star case. So how to approach? There is nothing like inflammatory hip pain and non-inflammatory hip pain. It will be 100% of the cases, it will be avascular necrosis. So how to approach to this case? After analyzing the symptom using Odipara and Licor, we have to directly ask about the past medical history. If in the past medical history, the patient tells you that the patient is a case of renal transplant and he is taking steroid, that the diagnosis is avascular necrosis. Sickle cell crisis does not come in India and Bangladesh. It is a case for Middle East. So regarding, doctor, to be hyperlipidemia can cause avascular necrosis, but I can guarantee you 100% hyperlipidemia will never be given as a case of avascular necrosis in PACES exam. This is from my side guarantee. There's a pattern of PACES exam cases. The most common cases given is the background of taking steroid. Likely the patient will be an hepatic transplant or renal transplant, and he is taking steroid, and right now he is having pain at the hip joint. That is avascular necrosis. And hyperlipidemia can cause avascular necrosis in real life, but in the PACES exam, you will never be given such case. Because what I want to tell you once again, you have to understand the pattern of cases, because by passing the PACES exam, you are entering into the ST3 level training. After that, you will be given history. After that, you will be given training for 4, 5, 6, 8, ST8, up to ST8. So after that, you will be declared as a consultant. So you'll never be given any case as consultant level. You'll be given a case as ST3 level. Yes, doctor, for any case of pain, we have to rule out any trauma. This is true for any type of pain. For hip pain, shoulder pain, neck pain, any type of pain, we have to rule out trauma. So for hip pain, we have to do certain steps of physical examination. That has been shown in the recording of the physical examination video. So these are the 3 cases, double star cases. Please tell me if anyone have any kind of question regarding the shoulder pain, then hip pain, then ankle pain. Please ask me if any question is there. Otherwise, I will move to the next 2 1-star cases. Or give me a sign that you don't have any problem. Is it clear to everyone? Should I proceed? Okay. The next 1-star case is neck pain and then diffuse body pain. For neck pain, how to approach to a case of neck pain? After analyzing the neck pain using the mnemonic Odipara, then Licor, we have to ask if there is any other joint pain. Then we have to ask whether there is any morning jamming. And if there is morning jamming, whether the morning jamming is more than 30 minutes or not. Then if the morning jamming is more than 30 minutes, then the cause is inflammatory neck pain. That is spondyloarthritis and rheumatoid arthritis. And if there is no morning jamming, the cause is cervical spondylosis. It can be due to cervical radiculopathy or cervical myeloradiculopathy. But this case has come one time in the PACES exam with the background, with the history of ankylosing spondylitis. The diagnosis was ankylosing spondylitis. It has come only one time in the PCS exam. That is seronegative spondyloarthritis. Is it clear to everyone? Please give me a thumbs up so that I can be assured that there is no question left. Okay. The last prompt of our today's session is diffuse body pain. This is also a less important prompt that has come up to now. I have found it 2 times. So after analyzing the symptom Odipara and liquor, we have to directly go to the differential diagnosis. So these are the list of differential diagnoses that are important for PCS exam. They are dermatomyositis, polymyositis, rhabdomyolysis, viral myalgia, osteomalacia, and polymyalgia rheumatica. Apart from these cases, no other cases are needed for diffuse body pain. So what are the screening questions for dermatomyositis and polymyositis? We have to ask for any, do you feel difficulty combing your hair? Then for any type of diffuse body pain, we have to rule out rhabdomyolysis. This is a must to do. Can anyone tell me how to rule out from the history the rhabdomyolysis? And yeah, wonderful, Dr. Kolakara. And these cases come in this diet. So some candidates are thinking some rare diagnosis like McArdle's hemoglobinuria or something like that. But for sure, McArdle's hemoglobinuria will never be given in the PCS exam. PCS exam, you will get simple cases like dermatomyositis, polymyositis. You have to rule out rhabdomyolysis. In the history, typically the patient will give you history like the patient is taking NSAID, the patient is doing excessive exercise like attending some marathon or something like that. After that, he is having some diffuse body pain, or there can be some recent history of sore throat indicating viral myalgia. Then osteomalacia can be there. Then polymyalgia rheumatica is another differential diagnosis of diffuse body pain, also bilateral shoulder pain that I have discussed earlier. And can anyone tell me one important safety netting? Safety netting is also important to get the full mark in the clinical communication section. You have to tell all the safety netting. So what are the safety netting there? Sometimes the patient can tell you that after going to the sun, I am having some rash. So at that time, you have to do the safety netting. You have to tell the patient that avoid sun exposure, and if needed, do some clothing, arrange some clothing, or try to cover your face. Sometimes you can be given a case like vitiligo. In that case, you have to do the safety netting that avoid sun exposure. In case of Raynaud's phenomenon, in the history, the patient can tell you history of taking propranolol for anxiety disorder. So during meeting consent, you have to tell the patient, stop this medication, and I'll talk to my consultant to replace it with a safer one, because this medication can increase your symptom. Like this safety netting, can anyone tell me, in case of rhabdomyolysis, if the patient tells you that for my diffuse body pain, I am taking painkiller, what important safety netting you have to tell the examining patient, otherwise you will lose your mark in the clinical communication skill. Can anyone tell me what is the safety netting here?
Stops NSAIDs.
Wonderful, doctor. Stops NSAID. Very much wonderful. These are very much simple things, but these things sometimes are missed by the candidates, and they lose the mark. Yeah, you can also give advice about avoid exercise, but stop NSAID will be the crucial thing. The examiner will keep his ear to know whether you are telling the patient to stop the NSAID or not. If you don't tell him to stop the NSAID, he will cut your mark in the clinical communication skill for sure. Whether you have asked all the PDF surgery, whether you have asked all the symptom analysis, only not for asking to stop the NSAID, you will lose your mark. So these are all the prompts for today from the musculoskeletal system. And the class is about its end. Sorry, is my voice breaking? Dr. Shubhadeep is saying. Please tell me, is my voice breaking or not?
Yes, in between. Now
Okay.
it is okay. Now it is.
Okay. So these are all for today. We have already discussed the prompts coming from the musculoskeletal and pneumatological system. So right now, what I will do, I will provide the recording of today's class to the active participant, and within tomorrow, I will give the access to all the PDF of the cases and also the recording of the physical examination, investigation, and management for each case separately. Yes, Dr. B has, yes, myasthenia cases, all the things are there. You will get all the things you need to know for long clinical consultation for myasthenia gravis. All the steps of examination are there in the recording of the physical examination, investigation, and management. So actually, this is a like marathon case. We have to do a lot of homework, and I will assess. I will actually poke everyone every day, whether you are doing the homework or not. The homework is basically you have to do the practice with your partner, the active participants of the other active participants of this case, because I don't want you to remain dependent on any specific mentor. Once you know how to approach to each case, and once you have all the possible cases that comes in the PCS exam, then you don't need for anyone's help. You just need partner. So try to build partner as many as you can and do practice. This is the only one thing that is needed to pass the PCS exam. And for PCS exam, only 30% is theory, but 70% is practice. For the long clinical consultation from this course, I will provide you all that you need from this 30% thing. And from my side, I will try to make as practice as you can. I will individually assess each one of you how you are doing the homework regularly or not, because you have to practice with me during the next session. I will exactly throw case from these scenarios, because these are the common cases. And it is, from my side, it is more than 95% guarantee that you will get common from these prompts. So what you have to do, you have to go through the recording if you want, and you have to make your note once again. Then you have to start the practice before the next class, because in the next class, you have to practice it with me. And this course will be completed over 10 sessions. The 11th session will be solely on practice. And each week, the class will be on Sunday and Wednesday. This will be the class time. And it will take only 5 and 1 week, sorry, 5.5 weeks to complete the whole course.
What is the timing of the class?
Actually, earlier the timing was from 7 p.m. But for right now, for today's session, I have taken the class from 9 p.m. But usually 7 p.m. is better because the course is usually longer. It takes a lot of time. Whenever the candidates start practicing, I have to assess each one of them. So during the first half, we have to discuss the prompt. Like that next class will be likely from GIT or neuro. So during the first half, we have to discuss the prompt that from the neuro. Then during the second half, we have to do the practice from these musculoskeletal prompts from the given case. So the next class will be from 7 p.m. Bangladesh Dhaka time and 6:30 p.m. Indian time. And the practice session will be started probably from 8:30 or 9 p.m. And recording will be available for all of the active candidates. So if anyone have any kind of question regarding the approach to each prompt or any code structure, please feel free to ask me. I'll be happy to provide your answer. And this PDF will be available to the active course participants also. And this is a must to understand the skill of the PCS exam, MRCP long clinical consultation exam. So if it is okay, then I can postpone for today. Okay, so thank you once again to participate today. And we'll meet again. Today is Wednesday, so we'll meet again on Sunday. Thank you very much. Thank you. So do the practice, doctor, do the practice, do the homework, do the practice. Do practice as much as you can, and you will get the full mark. Thank you, everyone. Good night.
Thank you. Excellent job.
Thank you, Apu.